All right, awesome. I will take that as our cue to start. Excellent. So thank you guys very much. I'm excited that you signed up for this, knowing that it is virtual, so it's a slightly different dynamic than being in a classroom. But I do want to try to have it be as engaging and conversational as it can be. So I do encourage you to ask questions, obviously take notes. If you need something to be re-explained in any way, please do make sure that you ask me that. What I would just say is that to keep yourself muted through anytime I'm lecturing, but if you want to ask something or have a question, then just unmute yourself and say, hey, and then ask the question. Just like if we were in a classroom or in a room setting that you would essentially just kind of chime in. We do have a great group of 18 professionals, partly because of the flow of things. It might be a little bit difficult for individuals to introduce themselves. Normally I like to do that. So I do apologize for that aspect here. It might be a little bit time consuming to do that with the logistical side. So what I'm going to do is jump on into the slides. If you did not get these slides, just email, shoot the message in the chat box. And then I'm making sure that I'm looking at that, making sure that everyone is fine on this computer, but I want to listen. So Karen, that's totally fine. If you don't have a microphone or don't have your camera, that is totally fine. Hopefully everyone is dressed. Looking at Katina's comments. Perfect. So again, if you did not get the handout, please either put it in the chat or email me education@ebfa-fitness. I will make sure you get a copy of it. Obviously, you don't need to reference that as we're going through this because I've got the slides right here for you. Cool. As we kick into this though, what I do want to do is if 3 people, so 3 people are going to have to kind of jump in and chime in and tell me why they signed up for this PreCon. So if 3 people can unmute themselves and just tell me what attracted you to this workshop. Have you heard Biopsychosocial before? Just give me a little bit of information. Who's our first person?
I'll start.
Okay.
This is Katherine Eyring with Aging Gracefully TV. And I work with all older adults from ages 60 to 95 actively with classes. So chronic pain is something I hear about a lot. And if we can affect that in a positive way with movement, I'm all about it.
Good. Excellent. Thank you so much. Anyone else? Who's our second person that wants to jump in?
I'm Sharon Burke with the Life Energy Foundation, and we actually specifically deal with chronic pain and sort of zebra illnesses or chronic conditions. And actually, we're just doing a webinar on Zoom fatigue, and we're specifically bringing up biopsychosocial influences.
Excellent.
So excited about this. Thanks.
Of course. Yes, that's awesome. Who's our third person that wants to share some information?
Good morning. Okay, so I did it only because it was you, Emily. I thought you were going to be talking about feet. I didn't actually read the title. Like, Emily's doing the thing. I haven't done it with her just yet. So let me go and do this. And so then I saw your slides last night and I was like, uh-oh, what did I get myself into? So I don't know anything about this. I've never even heard the word biopsychosocial before. So, so there, newbie, okay. Lots of coffee.
There we go. Lots of coffee, take your notes. And they are recording this. So I believe that they will be sharing this with you so you can hear back. I will ask Dan if he can do that. And sorry that it will not be referencing feet. Towards the end, I will a little bit, but that will be my sessions during the Functional Aging Summit. So thank you for the 3 that jumped in and shared a little bit about why they signed up. Real quick, my background and how I got into this topic. Biopsychosocial, which means what is your biology, psychological, and social influences on how you relate to yourself, how you relate to others, the environment, and then in this case, how you relate to a chronic pain diagnosis or a chronic movement dysfunction or movement disorder diagnosis. There's a lot of emotional layers that go into someone who's going through chemo and cancer, or has been diagnosed with MS or Parkinson's, or has a history of falls. So we want to make sure that we are appreciating the complexity of the processing of the way that our clients are presenting. Everybody's relationship to themselves and the stages in their life that they're going through are very individualized. They're very personalized. They need to be appreciated. I got into this concept because of my practice, and a lot of the patients that I see in my office are chronic pain patients and movement disorder patients. So a lot of the MS, Parkinson's, stroke, idiopathic neuropathies, things like that, where I started seeing trends in the presentation of the patient, and a lot of them just wanted to be heard. A lot of them were had some sort of underlying anxiety or depression, which probably was related to this chronic diagnosis, and were continuously asking for, what is the next thing? Is there anything else? Is there this? Is there that? And they were kind of grasping at anything. If you could imagine someone kind of falling and they're grabbing at the branches as they're falling. That's sometimes how these patients can present. And a lot of times all that they want is someone to just listen to them and hear that they are processing this in the way that they are. They can be very emotionally draining. So you have to be very, you can't take their emotion and embody their emotion. You can be compassionate and, patient and, loving towards them. But if you completely embody yourself in their emotions, then you now have their emotions that you're carrying. So that is something, as you get into this area of client, is that you have to be strong, absorb it, but not embody their emotions. So that's how I got into biopsychosocial. And then I build it into everything I do from a sensory perspective, my barefoot science, interoception we're going to be speaking about. And then a lot of the applications with the Naboso products are built around helping people feel safe and kind of feeding that baseline homeostasis for them. Okay, so that's what we're jumping into here. Okay, hopefully you're ready. All right, so I want you to ask yourself, just think of your client base that you have right now. Maybe you have a few key clients that you can think about, and ask yourself if you're doing everything you can to help that client, beyond just improving their balance or, reducing sarcopenia or building muscle mass, or they want to run a race or something like that. Are you doing everything that you can for them? This means that we really want to look beyond the physical aspect of our clients. And I will go into that so much more. Why it's important to look beyond just the physical is because you can have two clients, and you probably experienced this yourself. Two clients, call them, roughly the same age, same activity level. Both of them have, let's say, knee pain, osteoarthritis in the knee. One client of yours has the knee pain and is still super active. They feel the knee pain, but they don't let them slow them down. They're still doing their 5Ks and, playing tennis on the weekends and things like that, where you have their counterpart, same age, same activity level, same presentation of the knee arthritis, but they're completely embodied by it. They have so much higher perceived pain around that knee. They are constantly seeking, injections, and do I need surgery, and I want to get a knee replacement. And so they have these seemingly similar presentations. On the MRI, their knees look exactly the same. Why does one present one way and the other present another? That's really the biopsychosocial aspect, to try to understand how we can have clients seemingly similar, and according to Western medicine are similar, but they present so different. This is really where you have to go into and appreciate that we as humans are very complex. My experiences are very different than Marilyn's experiences. How I process pain is very different than the way that Dan processes pain. So we want to appreciate that complexity going in. And as I had said, looking beyond the physical. This is really important for trainers, coaches, movement specialists, physical therapists, because we deal with the physical, right? We deal with joints, right? Joints and muscles, things that we can see, things that we can touch. So we think that if someone has knee pain, as an example, then we strengthen the quads, make sure they have ankle mobility, strengthen the hips. So you look at it from a very physical basis of why they have pain. It's time that we look past that physical. This is really where you look at the biopsychosocial model. It's difficult for me to ask, but because of the setting, but if you have, you know, your videos on, or you're curious, I'm curious how many people have heard of biopsychosocial. Have a lot of you heard of it? If anyone wants to unmute themselves and say, yes, I have, or no, I haven't.
Yes,
again,
I have.
You have, okay. Great, so some people are putting thumbs up, awesome, great, okay, perfect. If you haven't, then great. I love introducing this concept to professionals for the first time. This is where this is a huge rabbit hole, and I have so many books that I can give you guys to read. We could start a book club on this topic. So if you want to, I'm serious. Okay, so biopsychosocial, thank you for typing that in. So biopsychosocial, this looks beyond just like the genetics, right? So your mother had anxiety, so therefore you have anxiety because of the genetic propensity. You know, that's a side. There's of course epigenetics, where I'm sure a lot of you have heard of epigenetics, which is the environmental influence on genetics, which is actually more powerful than genetics. Genetics, yes, lays the foundation, but the environment essentially kind of unlocks or allows expression of certain genes. So that's really the greater influence. A lot of that added onto it would be environmental, would be social. Psychological is kind of some of this processing of some of our first experiences. And then of course there's the nutritional side as well, that we can have side tangents into, you know, the gut biome, and people who have a gut biome that's not stable have a higher tendency for depression and anxiety. So very multifactorial, very complex, that we want to start appreciating that as movement specialists. So now if you think of the other side of it, so here we are thinking of all the environmental influences, biopsychosocial, holism is what it's called. The other side is where we think of a lot of traditional Western medicine. The way that I was taught to look at a patient is very biomedical. This is looking at, you have foot pain, therefore there must be something structurally wrong with your foot. So I order the X-ray, I order the MRI, and I look for the evidence of the structural presentation of why you have foot pain. But if the X-ray and the MRI come back as normal, then that's where the Western doctor would start to kind of scratch their head and say, maybe it's this, let me order another test. Let me refer to this person to do a different test. And it becomes very structural based, not factoring in the power of our emotional state and mind-body connections on that presentation. So there are limitations to the biomedical approach, the Western medicine approach. The you have knee pain, therefore it must be osteoarthritis on an MRI or on an X-ray. We want to, again, challenge ourselves beyond just that physical presentation. This is a way that you can kind of describe them from we'll call them adjectives. The holism or the biopsychosocial, this is where you get a little intuitive. So a lot of things that I will actually say to my patients and that you probably see with your clients is that it's just your intuition of something that you can't necessarily prove it on, you know, an X-ray or an MRI or something like that, but you know that that is drawing some of their presentation. It's emotional, subjective, holistic. It's typically more female is how they describe it, where more Western medicine, biomedical, reductionist, this is, you know, very logical, objective. I must see, you know, arthritis on X-ray. It's more seeing parts versus the body as a whole. And any approach from a holistic, integrative, functional is essentially biopsychosocial. So we want to see how we can apply biopsychosocial as movement specialists. As movement specialists, perhaps if our clients have chronic pain, a movement disorder, or movement dysfunction. This is very important when you're talking about chronic pain. Acute pain is completely different. You sprained your ankle, yes, go get your X-ray and look at it from a Western medicine perspective. You have recurring idiopathic neuropathy that is burning in your feet and there's no known cause. That is where we're starting to look at biopsychosocial. Fibromyalgia is another one. A lot of irritable bowel syndrome is a biopsychosocial influence presentation. Chronic fatigue, non-cardiac chest pain. So your EKG looks fine, but your client keeps going back with chest pain. What is causing that? That's where we start looking at mind-body connections. So living with chronic pain, I know a lot of you said that you have clients that are presenting with chronic pain or you specialize in chronic pain. You probably see trends within those patients as far as their relationship to it. Some people become identified by their pain. It almost becomes part of something very invaluable to their identity that they almost want to hold on to. And for teaching them to kind of move on beyond this chronic pain and don't let it be all consuming, that is actually changing a little bit of a person's identity. If you've ever read about like the ego is really part of that. The ego essentially validates what we know with ourselves. So some of that could be moving beyond that chronic pain identity from that ego side of things. But for our clients or patients who live with chronic pain, a lot of them are typically demoralized. This is what I was explaining in the beginning, that it essentially trickles down into a lot of aspects of their life, trickles into their family, their relationships with their friends seem to be all influenced by the fact that they have this chronic pain. They might actually start losing some of their relationships because they become so all-consuming of this chronic pain. And it really leaves these patients and clients looking for that pain relief. A lot of them do feel like orphans, and they may go from a trainer to another trainer to another trainer and say, I've heard such great things about you. You are going to be the one that helps me. And all these other ones before, they just weren't listening to me. And then it puts kind of like the world is now on your shoulders because they give you all of this, like, you are going to be the one that helps me. It can be a little like, shit, that's a lot of pressure that I want to be able to do this. But they keep doing that because they essentially emotionally drain one practitioner and they start getting frustrated, and then that practitioner essentially refers them to someone else. So we just want to appreciate what they're going through. I would say one of the biggest things through that is if they just know that you appreciate or you're hearing the complexity of the emotions that they're feeling, that is just huge for them. That's barrier one, to have them know that they're being heard. Now, a lot of this is referred to as functional syndromes or somatic syndromes. And I'm sure a lot of you have heard about psychosomatic disorders or somatic influences or functional disorders. All of those are biopsychosocial as well. Again, not presenting in a classic Western medicine way. All the diagnostic tests are negative, which means it's essentially a diagnosis of elimination, let's say. You can refer to this as body distress syndrome. So they have a body distress syndrome or psychosomatic syndromes. You, of course, never want to say that this is in your head because that makes a patient feel or a client feel that they're crazy, even though it is in their head because a lot of it is the emotion. Just wording it that way makes it difficult for them to connect to. These are a few of the conditions that I had mentioned earlier: IBS, fibromyalgia, chronic fatigue, non-cardiac chest pain, headaches, so chronic migraines. Idiopathic neuropathy is something I see a lot in my office, and I see the complexity of the emotions around that diagnosis because a lot of them are actually younger patients. Back pain, and then kind of a diffuse foot pain. And of course, there's many more on here. I had done a webinar on movement disorders, and when people present within this medically unexplained category, a lot of them can also have tremors. So there's something of it's a functional tremor, not showing up in the classic way, but they have almost like a Parkinsonian type tremor, but it's psychosomatic. A lot of them can also have a dystonia, which is like a muscle spasm. So dystonia is also a psychosomatic presentation that we might not think of typically in the first place. Now, oh, here we go. Look at that slide. Just read my mind. Okay, medically unexplained movement disorders. So these, like chronic pain, are very difficult to diagnose. Here, 50% of them, this is just reading my mind, 50% of movement disorders present with a tremor. Again, it's classically kind of like a pill rolling, non-intentional tremor. So it's a tremor at rest. And then the myoclonus, again, it's essentially a contraction and a release. So myoclonic movements are kind of jerks. So you can think of it that way. Parkinson's is something as well that you will see, that they start to shuffle and do the hesitation through doorways and turning. Very classic presentation of Parkinson's, but there's a few inconsistencies that do not hold the true diagnosis. Something that's interesting that you will see is that psychosomatic movement disorders are typically seen where someone else in the family has a movement disorder. So they're essentially mirroring or mimicking that individual as a way of expressing their emotional processing, let's say. Another one that's very interesting that is psychosomatic is Tourette's. So when someone has, or a tic, when someone has a tic or Tourette's or a stutter, those three things are very high in a psychosomatic biopsychosocial presentation. And a lot of them have to do with the, some sort of emotional trigger brought it on. Tony Robbins, I'm sure you guys are familiar with him. If not, please check him out. He's someone who'll kick you in the ass and wake you up. Tony Robbins, being a motivational speaker, he's also an NLP practitioner. He gave this example of someone that he was working with who had stuttered since he was around like 3 years old. And since 3 all the way to 40, he was stuttering in a way that it would prevent him from holding a job. He couldn't speak in public because of his stutter. Went all the way back down with Tony Robbins through his NLP work of when was the first time you stuttered? When do you remember stuttering? And he said that he recalls watching these cartoons, and there was a character on the cartoon that stuttered. And his parents were fighting. His parents would constantly fight. That's all he remembers from his childhood. And he found that if he mimicked the cartoon character by stuttering, that his parents would stop fighting. So he carried that all the way through. That's what you see a lot with medically unexplained movement disorders, psychosomatic. It's something that it causes someone to stop. If a child wants attention to stop the parents from fighting, they might say, my knee hurts, my elbow hurts, my chest hurts, and then they just start to kind of wrap into it. That's just a small example to appreciate the complexity of presentations that we see in our clients and why it can be really frustrating as the one doing the diagnosing. So what is one of the biggest biopsychosocial influences and associations with medically unexplained pain or movement disorders? What's one of the biggest triggers? If you have the slides, don't look ahead for the answer, but try to guess. Someone unmute themselves and try to guess. What's one of the biggest triggers? Why do I have non-cardiac chest pain?
Stress.
What was that?
Stress.
Yes, good job. Who said that?
Marilyn.
Marilyn, good job, Marilyn. Yes, stress, 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 stress. Stress in a childhood, stress throughout your adulthood. Stress is obviously very complex. Stress is all consuming, especially right now. 2020 is like the year of stress. It is just like, how resilient are we is what this year is testing us. So stress, yes. This is everybody's individualized stress. My perception of stress is very different than my husband's perception of stress, and probably from all of your guys' perception of stress. Now, what's interesting when you look at stress is that a lot of stress is not conceivable. Like, I don't know that I'm stressed out. Or a lot of our clients ourselves don't know that we're stressed out. If you are stressed, you could either type it in or unmute yourself. If you know that you're getting stressed, what do you typically see, feel, or perceive?
I would like to eat when I'm stressed.
Okay. And so that's actually interesting. So Vicky said that, right? Okay, so Vicky likes to eat when she's stressed, and she does that. Why do you do that? Do you know why you do that?
I'm assuming because I have to ignore the other things, and I just get to stand in the pantry instead. Whatever it is I need to face.
So what's really interesting with that, so you can understand for your clients that do eat when they're stressed. So one, when you eat, if you've ever noticed, kind of eating, especially when you're eating alone, is that you're forced to be in the now. So eating slows you down and you are really present. Hopefully you're present, eating. So you essentially are just in this moment. You're not thinking of future. Future thoughts make us anxious. Past thoughts make us depressed. So when Vicky is eating, she is just in the now. Have you guys heard of Eckhart Tolle? Right? The power of now. It's something that I highly recommend to literally all of my patients and to friends and colleagues and all of that. Is Eckhart Tolle's The Power of Now is really showing what happens to the mind and the body when we are just in the present moment. So eating forces you in the present moment, but what it also does is that it is influencing our gut, which we're going to go into interoception. And now when you're eating and your stomach has nerve endings, that now you're essentially stimulating those, and it gives a perception of comfort or safety. So that association of eating, being in the now, slowing down, feeling that internal sensation of food, and then you're also touching something. So that's many layers: touch, moment now, gut, interoception, I feel safe. Is essentially what it's creating. I just want to go, a few people had typed in, some things. Anyone else? What other symptoms of or presentations of stress? How do you know if you're stressed?
Sleep issues.
Okay, it throws off sleep. Okay, the mind is going, right? So insomnia, poor sleep is one of the greatest contributions to or side effects of being stressed. Of course, that throws off your cortisol now, right? So when you don't sleep well, part of it is because your cortisol is thrown off, but then it also further throws off cortisol. Anyone else? How about another one or two symptoms of stress?
Impatience.
Okay, that's a really good one. So impatience. What happens when we are stressed is your stress threshold or your trigger threshold becomes lower. So you are closer to the like, don't cross the line, like where maybe you get pissed off or you kind of like just react to people. You get closer to that threshold when you are stressed. What's actually happening is that you are now being driven by the amygdala, where we'll show a slide moving forward about the different parts of the limbic system. And the amygdala is your emotional center, your heavy emotional center. So when people are very quick to kind of react emotionally, you could theoretically say that they are now being driven by their amygdala. They're amygdala heavy. Where normally when we're not stressed, you start to feel a sensation, maybe you start to get irritated, it triggers your amygdala, but our neocortex, our consciousness can override that. And you can then say, okay, Emily, deep breath, calm down, it's okay. So you have this override system that starts to get shut down the more stressed that you are. That's also very heavy influenced by your gut biome. So when your gut biome is thrown off, it dysregulates the way that the neocortex kind of bypasses or slows down the amygdala, kind of from a gatekeeper perspective. So I'm just looking at a few other responses. An increase in heart rate, so that's great. So you start to maybe get palpitations. You start to shake a little bit. I get a headache when I'm stressed out. Some people, difficulty concentrating, absolutely. So I'm glad that Chris mentioned that. So the reason why we have difficulty concentrating and difficulty learning is because when you are stressed, that's a threat, you are in survival, you now essentially go back into your primitive way that you process your needs, and your ability to concentrate on other things is very low on the kind of survival totem pole, which means you're just focused on one thing. Reading a book is not a high priority when you are stressed. That's huge when it comes to learning. Pain, any pain might jump out. Absolutely 100%. Body temperature goes down, blood pressure drops. Ooh, Sharon, make sure Sharon does not get stressed out. Okay, Sharon's blood pressure goes very low. We don't want her to pass out. Struggling to make decisions. That's great, Peter. Karen likes to drink alcohol. Right. I love the honesty. I love the honesty. Okay, great. So what we can see is that you recognize these things, but perhaps your client is not perceiving that. Maybe your client doesn't realize that they eat more when they're stressed. And if you do a food log and kind of track them that way, you might actually be able to correlate and then bring the pattern to their consciousness, which is great. Now, what's interesting is that in today's society, people are so used to being stressed out, like they kind of, like, I'm a type A personality, I just run on caffeine and stress, or, or adrenaline, right, which is stress, right? And when people actually slow down, that's when they start to actually maybe get more stressed. So it's the absence of stress or lack of adrenaline that actually freaks people out, which is quite interesting. So people become addicted to their own stress hormones, cortisol, adrenaline, caffeine. And then what's interesting from seeing a lot of these patient intake forms in my office here in Manhattan is that I would have so many patients that would be on a stimulant, and then the next side of their medication would be Ambien or like a sleeping medication. I mean, so many that my assistant, I remember one day she's like, everybody takes Ambien and everybody is on like Adderall or something. Like it surprised her, but it didn't surprise me. But it's quite interesting to see that. So now what's also interesting about stress is that it's not something that should be subjective. Like, I feel stressed out. Well, my perception or my scale of stress is very different. We need to be looking at it objectively. So this is where you actually have your clients go get their cortisol levels tested. Does anyone do that now? Recommend that their clients, you can type it in the chat or kind of say, yes, I do that or not. Is something that I would recommend. It's a very easy test that you can do. You can do urine cortisol. Of course, they can do blood cortisol. Great, Sharon, that you do that, right? Because people don't know if they're stressed or not. So I would have that be something to do. Find a specialist that you work with and have them do a cortisol test and then really gauge that. If they're not sleeping well, you know, you have to check that. If they are having a hard time losing weight, you want to check that. Let me just check in the, okay, have not yet. Yeah, great. So you want to do that. And then you want to actually check for yourself as well to see what your cortisol levels are. So here are a few stress statistics for us to get a better understanding of this, knowing that we are stressed as a society. So percent of people who regularly exercise, caused by stress, 77%. People who experience psychological symptoms of stress, this would be the anxiety or depression. So 70% of people, these are US statistics, feel that their stress has increased over the past 5 years. Half of people, probably now almost everyone in the US would say. Money and work are some of the #1 causes of stress. And then a lot of people, here's the insomnia that someone had mentioned, lie awake at night due to stress. I know I have been very stressed because of COVID and have not slept well in 3 months because of it. And I'm sure that a lot of you can kind of echo on that same thing. So these are some of the top symptoms of stress. Fatigue, so chronic fatigue. Another big thing that you want to think about when it comes to fatigue, is stress related, but fatigue is also gut biome. And I don't mean to keep beating the gut biome down into the ground, but it is so important. A lot of people with chronic fatigue have a gut dysbiosis and then actually have a blood-brain barrier dysbiosis, because the barrier in the brain is exactly like the barrier in the gut. The permeability is sensitive to inflammation and infection and certain viruses, kind of around COVID. I had done a free webinar, which is sitting on our YouTube channel, on the blood-brain barrier and the permeability post-infection, inflammation, viruses. So if you want to check that out. Fatigue is one of the classic presentations of increased blood-brain barrier permeability. Your client potentially has brain inflammation with fatigue, chronic fatigue. Headaches, again, huge symptom of stress. Upset stomach, tension, people are putting it somewhere. Loss of appetite or increase of appetite. And then teeth grinding is another big one that we will see. My YouTube channel is, I'm gonna type that in, it's youtube.com/EBFA Fitness, and you will see all of our lectures on there. Okay. All right, so when it comes to stress, okay, it really is not stress itself that is killing us. It is our reaction to it, or it is our interpretation of that stress. So if you see stress as something that truly just increases your focus and you are motivated by being a type A personality and you love to be busy and deadlines just like, woo, they get you excited, right? You might not have any objective uptick in your stress markers. It is the person that has potentially a low trigger of stress and is completely embodied by that stress. That's the difference of what we need to understand with this. Now, this is our cascade of stress response. you have a threat. That threat could be possibly getting sick with COVID. It could be, you know, a deadline. It could be that you are giving a speech in public. It could be your taxes. It could be, right, whatever it is. So a multitude of that threat. Now, you as an individual or your clients are going to interpret that threat. Yes, you are going to interpret your risk of getting COVID, or, you know, your taxes due, who knows? And then you interpret that as low threat, middle threat, high threat. So where are you going to put this on your threat Richter scale? Okay. Now, if you see it as something that you can actually get past, you go into a fight or flight response, a sympathetic response. And I will go into these in more detail. Right? So, okay, I can tackle this deadline, or I can tackle this speaking in public. Or let's say you actually perceive it as a higher threat. Then what happens is you actually just shut down. Okay? So if someone is, you know, about to, you know, rob you in your face, some people, if they're trained in martial arts, might be like, come and get it, right? That would be my husband, where I would probably just shut down. I'd be like, take my bag, and I'm on the floor passed out, right? Because we would interpret it completely different. That is our stress response. And then after your stress response, we go down into our baseline, which is rest and digest. I'm sure that all of you have heard of the fight or flight, rest, digest. We're going to go into that, but delve into it even further. Now, let's say if the threat persists, so it's a chronic threat or a day-to-day threat, now we get into our HPA axis, or your hypothalamic pituitary adrenal axis, and we release cortisol. And then the cortisol is everything that we've spoken about in the past of poor sleep. You get increased central adiposity. It decreases your immune system. And then something that's really interesting is that the longer that stress persists, your body actually releases oxytocin. Now, we typically think of oxytocin as what? You can type it in, or you can unmute yourself and say.
Related to pregnancy.
Right, pregnancy, and then what else? If I hug you, right? If you hug anyone, any person, hug, touch, right? So hugging past a certain time, like not a 1 second hug, but you know, holding someone, you actually release oxytocin. Connecting, bonding, touch, love, not just with a baby, but with another human being, releases oxytocin. Yes, it's a comfort and a pleasure hormone. This is also a stress hormone. How cool is that? So your body with prolonged stress actually releases oxytocin. And I don't go into it too much here, but you can definitely go down that rabbit hole. And if you want to learn more about it, it essentially shows how us as humanity is really about survival, right? We have these threats and we kind of fight or flight, and we're kind of like quick to respond. And you could kind of say the situation where we are now. And then as that persists, your survival kind of changes. That in order to get past this chronic stress, I need camaraderie. I need my people near me. So it releases the bonding, love, comforting hormone to try to bring your team together to then get past this stress. This is the tend and befriend response. So if you're like, that is fascinating, let me read more about it, that's what you want to search, is tend and befriend responses to chronic stress. And that is release of oxytocin. I'm going to reference in a moment Dr. Stephen Porges. His wife specializes in this research area, oxytocin release. All right, so we had already mentioned this, but again, just another repeat. I think it's a great slide that stress can be defined as real, but it's also interpreted. And it's this interpreted threat, a threat that might not even be there. And it is physiological or psychological, or it's a threat to our physiological or psychological integrity. And then it creates a physiological and a behavioral response. The stress is a threat to my being or to my mind. And then I have a response in my body and in my behavior. That is what stress is doing. Now, remember that stress is perceived, individualized, right? We want to honor that stress cascade because it is there to help us survive. So you never want to look negatively at someone who may be stuck in survival, or you want them to begin to appreciate that they are in survival because their body wanted to protect themselves, and they should be appreciative that their body was able to do that and protect them. Now they're stuck in survival, so how do we get past it? But step one, you want to honor that. Okay. Has anyone ever read the book, Why Zebras Don't Get Ulcers? Whoops. Is anyone? If not, yes, great. Okay, thumbs up. Okay, if you have, great. If not, that's a book that I recommend. There's another book called Waking the Tiger. Waking the Tiger. I don't know if anyone has read that. Waking the Tiger by Peter Levine. And that is a book that is incredible, based off of the evolutionary stress responses or primitive stress responses, and how animals in the wild respond to stress, and how humans should actually learn from the animals in the wild so that we can better process or actually close each of our stress responses, is really what it is. So let's go into in the wild and then see how we can think of some of our clients on how we can use this to help them. So you're a zebra and you're hanging out in the wild, you're eating lunch with your friends, and then all of a sudden a lion starts to come. You sense it, right? You can hear the branches starting to break. So you start to kind of uptick. You perceive a threat. Now the zebra is interpreting the level of that threat. Okay, they think of it as moderate right now. So they start to kind of gather with their other zebras and they start to run because they can start to hear the lion. So they're starting to run. They truly believe that they can get away. So they stay in a sympathetic response, fight or flight, right? So I'm running. Now, if the lion gets closer, the threat goes higher because they actually think that they might get eaten. So what happens is they now go from fight or flight to the higher threat response, which is a freeze response. And what the zebra does is they pass out and they play dead. So the freeze response means that they thought the threat went higher. Their body shuts down. The reason why their body shuts down, just like our body would shut down if we perceive a threat too high, is that one, they want to play dead, because if you're a dead animal in the wild, the chances of another animal eating you or continuing to attack you actually goes down. Animals are all about the hunt. They don't eat just dead carcasses that are on the floor. It's part of that actual hunting aspect. One, they know that the meat is good if they're chasing you. So if you're dead, the meat might not be good. They might get sick. So the chances of eating you are lower. Second thing that it does is it actually decreases your ability to sense that pain. So you will not feel as much pain if you shut your body down. So those are the two benefits of shutting down. Now, let's say the zebra passes out, the lion gets to him, the lion sees that he's potentially dead. So the lion gets bored, goes away, runs away. What the zebra does is it stands up and it does something very characteristic. Does anyone know what the zebra does? Either say it or type it. If you've read the book or you just know from it. Anyone, what does the zebra do? It shakes. See if you typed it in. Yes, Yep, Jamie shakes it out. Shakes. I mean, like violent convulsing is what the animals do. You can go on YouTube and actually see the way that animals in the wild come out of a freeze response. Yeah. Dr. Stephen Porges, which I'll mention again, Dr. Peter Levine references those. So they shake violently. And what that is doing is, if you think of it this way, that you're running from a line, right? You have all that energy, all that adrenaline, like your muscles are massively contracting and they're filled with blood and oxygen, right? And then you play dead. You still have all of that energy within your being that you need to get rid of. So as soon as you come out of the freeze response, all of that adrenaline from your fight or flight response has to get let go. You have to get it out of your body. Yes. And then if you do that, you essentially close the loop, the stress loop, close, and then you go back into your rest and digest. So the zebra shakes violently, gets them back down into a parasympathetic state, and then walks off and goes and has lunch again. Right? And then they're fine, and they never hold on to the back stress or the back threats that had essentially happened to them. Of course, they learn from them, but they're not, it's not a paranoid zebra that has anxiety or depression, is essentially what it is. So for us, what happens in humans, which is very fascinating when you start looking at Dr. Levine's work and read the book, Waking the Tiger, is that we have a stress response, fight or flight, or maybe it goes into a freeze response, and then our consciousness essentially overrides and blocks the completion of that stress response. Here's an example. I don't know if you've ever been kind of so angry at someone that you start to shake, maybe, right? So this was when I first had my baby. She's now 10 months old, but she was, I don't know, like a month old or something. And our neighbors were being really loud, and it was, you know, late in the morning or early in the morning, and they were having a party, and it was like just pissing me off because I didn't want them to wake the baby. So I go over there and I'm like knocking on the door, and I just kind of like lost my mind. It's probably post-pregnancy, lost my mind. But I came back into the apartment, and because I was so pissed at them, like I was just like, oh, if you like wake my baby up, I'm gonna kill you. And then I come back in and I was like shaking, right? And then we would be like, it's okay, like stop shaking, calm yourself down, which means I was cutting off the ability for me to close that loop, and I was kind of compartmentalizing it and just squishing it down. What I should have done is just been like, shake, Emily, shake it off, and just let myself shake as much as I needed to close the loop, get myself back down into a parasympathetic state. I'm just kind of within your own mind to see if you have any examples of stories like that, or the next time if you ever happen to have a stress response and you're shaking, right? Or you almost get hit by a car and then you're like, woo, like you're shaking. Let yourself shake to close the loop versus cutting it off. What we do a lot, and what a lot of our clients do, is if they have a stress response and they cut it off, that energy is actually still percolating within their body. It's somewhere within their being that they need to release. So they completely keep trying to push it down, and then it represents itself as depression or anxiety or PTSD or panic attacks and things like that. Now, the other one related to this freeze response is going to be like depression, or depression is disassociation, which is detachment from the body. So when people have a history of stress that goes to the threat level of a freeze response, oftentimes they will present with more of a depressed state, where sometimes we might be curious of, you know, why is Johnny depressed and Jane is anxious, right? It has to do with kind of your interpretation of stress and threat. So let's go into just the classic autonomic nervous system and kind of the Richter scale between the two. Is we have sympathetic on one side, parasympathetic on the other. The sympathetic is what a lot of people will think of as the fight or flight, and then the parasympathetic is the rest digest. And then a lot of times we just think that we go back and forth between this, like we're hanging out, we're rest digest, and then we get stressed out. So we go into a fight or flight state. And then after that, we come back down and we're back in parasympathetic. That's where a lot of people will relate the autonomic nervous system, not knowing that there is a third, which is this freeze response. Okay. Again, we'll go into that more. Now, the way that you can think from a simplistic perspective of the sympathetic parasympathetic control is that the parasympathetic system is the brake on a car. It's the brake on a car. So you're a car going down a hill and your foot is on the brake, which is the parasympathetic system. If you want to go faster, you're going down a hill. If you want to go faster, which is sympathetic, do you even need to push on the gas, or do you just lift your foot off of the brake and you go faster, right? And then if you want to slow down again, you put your foot back on the brake. So your autonomic nervous system, which is you going down the hill, is controlled by the brake. Just, is your foot on the brake? Is your foot off of the brake? The brake is your parasympathetic system, okay? So everything autonomic nervous system is under the control of the parasympathetic system. It is the muscle that you train. So between the two, sympathetic and parasympathetic, which of the two do you think is faster? Which one actually controls our system faster? Type it in or say it out loud. Which one is faster? No, not yet. Which one is faster? It's actually, everyone thinks it's a sympathetic, right? Because we get we can get into a defense mode really quickly. It's actually your parasympathetic system. Your parasympathetic system is faster. Yes, Peter, it's parasympathetic. So everything, the muscle of your autonomic nervous system, the muscle of your emotional state or your heart rate state, your vagal tone, all of that, what you are essentially under control of is the parasympathetic. So it's you quickly coming off of the brake or on the brake. So your parasympathetic system is faster. Now, 80% of your parasympathetic system is the vagus nerve. So if you've heard of vagus nerve, vagal tone is often associated with heart rate variability. So in your notes, I would put parasympathetic equals vagus nerve equals vagal tone equals heart rate variability equals stress barometer is essentially what it would be. So someone who has high vagal tone has high heart rate variability, has high stress resilience. The higher your vagal tone, the higher your stress resilience. Okay? Your vagus nerve is the parasympathetic system. Remember, your goal after you get stressed out is to get yourself back down. We want to have a stress response. It's protective, but we need to get ourselves back down faster. That's the muscle you train. Okay? So if you've ever heard, increasing vagal tone, I don't know if you've ever heard that. It's ways that you can essentially strengthen or tone the subconscious nervous system, which is the autonomic nervous system. Some of the ways that you increase vagal tone are cold showers is one of the most common and most effective ways to train your vagal tone. Yes, 100%. Again, many pathologies cause people to live in the sympathetic domain. 100%, Peter. I agree with you 100%. So we want to see how can we, if their diagnosis keeps them in sympathetic, how can we help them become more parasympathetic? How can we increase their vagal tone is essentially what it is. So the list of your vagal tone exercises, I'm loosely using these terms, is cold showers is one. So cold showers increases vagal tone. It stimulates your vagus nerve. Chanting, humming, singing, those three. Vagus nerve controls your vocal cords. So you want to do chanting, humming, singing. That will increase your vagal tone. Breathing, yes. So diaphragmatic breathing, box breathing, reverse breathing, any sort of breathing exercise that you know and you do, any of Wim Hof stuff, it increases vagal tone because it upregulates the parasympathetic system. Gargling is another one. You can do that. So you want to stimulate the gag reflex. The gag reflex is part of the vagus nerve. So it's weird, but I'll tell you anyway, because it's fine. Every morning when I brush my teeth, I brush my tongue because I was told that you're supposed to, but I do a gag reflex. So I brush my teeth and I stimulate a gag reflex. Every morning when I brush my teeth, I've been doing that for years. That's a vagal tone or a vagus nerve stimulus, right? So that's kind of a way that you can do it. Fasting. So doing any sort of fasting, getting your gut biome in place is another one. Yep, 360 breathing, absolutely, is another one. Mindfulness, yes, 100%. Mind, body, meditation, yoga, tai chi, that is a vagal tone driver, okay? So just so you know, so you're using it the right way, someone who has high vagal tone, again, you have high vagal tone, means that you have more stress resilience. So you are able to bring yourself down back to a parasympathetic state the higher your tone. And that's where we want ourselves to be, okay? Now the term heart rate variability, and then, yes, Peter, I will be. Heart rate variability, so fasting stimulates, you're essentially regulating the gut and the gut lining. So Vicki, I'll go into kind of some of the intermittent fasting, which can have an acute increase in stress, but for the long term, actually increase stress resiliency, okay? Great question though. So heart rate variability, if you've ever heard this now, heart rate variability is an objective way that you can measure your client's stress. We like objective, not subjective. So objective, heart rate variability with either a heart rate monitor, they have the Aura ring. There's a lot of the smart tech that you wear now and it can measure heart rate variability. The higher your heart rate variability, the higher your vagal tone, the higher your stress resilient. So if you are tracking your clients with chronic pain and chronic diagnoses, and they have low heart rate variability, you know that your client is stressed. And now when we're stressed, your perception of pain goes up. So let's say it's a chronic pain client. The lower their heart rate variability, the more stressed, you could say they're stressed out or they have more stress, the more you shift into what's called allodynia. So allodynia means that something that should not be painful is perceived as painful by the individual. Allodynia, okay? Allodynia increases as your stress increases and your heart rate variability goes down. You increase heart rate variability by increasing vagal tone. You can call them synonymous, okay? And then on the emotional side, the higher the vagal tone, the higher the heart rate variability, the more emotionally flexible your client is. So they regulate their environment better. They don't react to the environment. They kind of anticipate the environment, let's say. Okay. Vagus nerve, parasympathetic. Now, that's part of it. Peter, here it's coming, right? That's part of it. Fight, flight, rest, digest. That's not all of it, because we have, dun, 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 the polyvagal theory. The polyvagal theory is what I had referenced earlier with the animal in the wild. It is essentially saying that we do not have just one vagus nerve, which is what we said. Oh, but vagus nerve is parasympathetic. Okay, this gets confusing then, sorry. Because you don't have just one vagus nerve, you actually have two vagus nerves. And the way that you can think of the vagus nerves is that you have a primal one and you have a mammalian one. So you have like a reptilian vagus nerve and you have a mammal vagus nerve. When you think of anything that is reptilian, what do you guys think of? Like a reptilian responses in the body are what? And you can type it in if you want. What are reptilian responses in the body? Going once, going twice. Oh, here my chat opened up now. Lizard brain, yes. Lizard brain means what though? Survival, beautiful, good, yes. Right, so the reptilian, really what they care about is survival. They don't care about the outfit they're wearing or if, you know, that lizard likes them or anything like that. It's survival. So when we are in our reptilian brain, which is our brain stem, right? Our brain stem is reptilian, or if we are in the reptilian vagus nerve, it goes into reptilian responses. You probably know where this is going when it comes to these fight or flight responses, okay? A reptilian response, do you think a reptilian response is going to be fight or flight or freeze and play dead? What is a reptile going to do? Which one theoretically can you go on like very low oxygen for a long time?
Freeze.
Freezing, 100%, right? A reptile plays dead easier than a mammal, right? So a mammal is more built around a fight or flight response. So it's a way that you can kind of think of these, okay? The reptilian response is a freeze response because a reptile can technically play dead longer than a mammal because they can go longer without oxygen, right? They can kind of shut their body down. So let's take a look at the polyvagal theory. This is what's happening here, okay? So we have what's referred to as ventral vagus. So you have a dorsal vagus and ventral vagus, or you could say, like in your notes, I would say dorsal vagus equals, you know, reptilian vagus, or it's also referred to as old vagus. So it's old vagus. All of those are synonymous, okay? That is the freeze response. That is where the threat level has gone to its highest. Your body shuts down to protect itself. Now, the middle ground that everybody knows, sympathetic, stays the same. It's fight or flight. That is true, right? I feel a threat, but I think I can get past it by either fighting them or running away from them. And then the new vagus, or the mammalian vagus, is really your parasympathetic that we know it, right? That is what Stephen Porges calls your social engagement. So your new vagus, or the mammalian vagus, really controls the face. So the vagus nerve controls the eyes, the muscles of the inner ear. So you can change your facial expression based off of your perception of threat, let's say. And we read people's faces and expressions before they even speak, right? The way that someone looks, we know if they are friendly or not, right? So we use that as a way to gauge interactions, but also that threat, potential threat of that interaction. So by being socially engaged, you will then actually kind of relax the muscles that are sitting around the eyes. The other thing that it does, which is very, very fascinating, is that your vagus nerve controls the muscles of your inner ear. And when you are in a threat state, or you're starting to perceive threat, or you're in survival, let's say, the inner ear muscles change that you hear certain frequencies and you don't hear others. So the rumble of animals running in the wild, or the rumble of like the vibration of a truck, right? You hear those more when you are in survival, because you're perceiving threat, you're trying to anticipate threat. Whereas higher voices, like maybe some female voices, you might not hear if you're stuck in survival, which is very interesting, of where people say they can't concentrate, or they can't learn, or they aren't able to process certain things auditorily because they're in survival, actually has to do with the muscles of the inner ear and what you can and cannot hear or filter out. Stephen Porges does a podcast, 2 of them, very fascinating, with Dave Asprey on Bulletproof Radio. If you just go to YouTube and search Stephen Porges' Polyvagal Theory, you can get several, like 1 hour long lectures of him going into this, which is highly fascinating. I encourage everyone to listen to those, because it really changes the way that you look at a lot of things when it comes to survival and threat and things like that. And it helps you to understand your clients more, that they might be very sensitive, that if music is playing in one room and you're trying to talk to them and then they just get distracted and they kind of shut down and don't hear anything, that has to do with their vagus nerve and the inner ear and the way that they're perceiving these things. So you might start to notice some of those trends already with some of your clients. Is the inner ear related to the feeling of dizziness if you are stressed? Potentially. So what is controlled with the vagus nerve are the muscles. So the muscles of the inner ear, which influences the tension of the eardrum and the frequencies that you hear. So it was, I don't know. I don't know how to answer that, but it is interesting that that could be part of that. And this is Stephen Porges. I'm just writing it down again. There was a slide, but Stephen Porges. Okay, great. Feel I am under the threat. So Judy just had a comment as far as tinnitus from a car accident, 100%. So Judy says that she may have tinnitus ringing in her ears from a car accident. Does that still mean that perhaps she's in some level of threat? Yeah, absolutely. It could be. Yep, great question. All right, so this is where we're at, and this is to help us understand. So let's go just a little bit further. And let me just check our time. Good. So I do have breaks that are built in. So once we finish this concept number 1, we will take a break. So hopefully you guys are staying with me and focused and intrigued on this topic. So a balanced autonomic nervous system is necessary for managing stress, managing our emotions, managing pain, managing postural imbalances, how we breathe, plus more. So autonomic nervous system is critical if you're starting to see trends of biopsychosocial or psychosomatic influences with your clients. So here's our vagus nerve. Your vagus nerve, cranial nerve 10, innervates the muscles of the throat, organs of respiration, and organs of digestion, which is where gut biome fasting influences vagus nerve. Breathing exercises influence the vagus nerve. Chanting, swallowing, gagging, all of that stuff influence the vagus nerve. And then the two branches we just went into. Dorsal vagus, already mentioned this. This is your old vagus. This is your reptilian vagus. This is associated with shutting down, slowing down, depression. People who are stuck in their old vagus, we're going to do a vagus assessment soon. People who are stuck in their old vagus or the dorsal vagus typically present like this: depression, difficulty sleeping, poor digestion, poor digestion to the constipation or the bowel side of things, postural weakness, and body disassociation. So poor awareness of where their body is in space, which is exteroceptive or kinesthetic awareness. We could tie that in as well. This typically is referred to as a red light reflex. So shutting down or a red light reflex, a withdrawal reflex, or you typically see them in a flexion response. So they posturally carry themselves like a picture to the right. So they're kind of rounded forward. They have tension in your abdominals. If you see the way that this woman is standing, you can see that she's going to have very poor diaphragmatic release or mobility. So she most likely is breathing shallow or in her upper lobes with this, which is sympathetic breathing or survival breathing, because of posturally, she just can't open her rib cage enough. Tension typically in the pelvic floor. So I find that a lot of people that are stuck in survival, kyphotic, yes. People that are stuck in survival put tension in their pelvic floor. So this is where they put tension in the perineum or the pelvic floor, and it can lead to a lot of pelvic floor imbalances. A lot of the stuff that we go into in all of my other lectures, my EBFA lectures, and some that I'll be doing for FAS this weekend, is diaphragm pelvic floor is your foundation to stability. So just from a movement stability perspective, if someone isn't breathing the right way, their diaphragm and their pelvic floor cannot stabilize the body for dynamic movement. If someone is putting their tension in the perineum, same thing. It's going to throw off the way that they stabilize the pelvis, their hip joint, the SI joint. All of that starts to get thrown off. So Vicky, we are going to go into that. Don't worry. So Vicky, we will answer your question as far as what do you do if you see that, right? How do we help that person? So now the ventral vagus or the new vagus, this is going to be our socialization, right? So this innervates small muscles of the face. It opens your airways. It's associated with positivity, relaxation, and social engagement. And then of course we have our fight or flight. Okay, so we know these. So this is a fight or flight response. This is a green light reflex that we can see. This is where someone is ready to fight, action, they're ready to run. So their head is higher so that they can see, right? They're not hiding, they're actually trying to get ready to run. You see different postural imbalances. They have tension in their scaps, overactivation of the back extensors, a lot of tension in their glutes. So these are different postural imbalances that you see that have a autonomic nervous system influence or a emotional influence tied into it. And yes, we go into this. Posturally, if I just said you have someone with tight glutes and tight back extensors from a actual physical perspective, you would probably know what to do. Or if someone has an upper cross syndrome, right? You know what to do. You know to release the scaps, you know, or release the pecs to get them here, to strengthen the rhomboid, to get them into the postural. You know how to fix someone's posture physically, but now I want you to appreciate that there are trends in the emotional autonomic nervous system characteristic that drives why someone is in a upper cross, where someone is in an extension. Okay, so now here's the $1 million question. How do you tell if your client is stressed out or is stuck in the dorsal vagus? We already said you can tell them, one, to get their cortisol levels tested. Two, you can measure their heart rate variability. So this is kind of our stress assessment. Cortisol levels, heart rate variability, technically you can measure inflammation, because inflammation in my office I use as a stress marker. A lot of people who are have increased stress typically are inflamed as well. So these are going to be a couple other ones. What state is your client in? This is the first one. This is hard to do to yourself. Yes, you can watch their breathing pattern, Peter. That's a really good one as well. Is you can measure their pulse. So you can try to do this on yourself and see if you notice it, or a family member, friend, client later. Is you're measuring the pulse. And what happens when you are in a balanced vagus nerve state, you're not stressed out, you are in ventral vagus, parasympathetic, is that when you inhale, your pulse goes up. So every time you inhale, you will notice that your pulse accelerates. Okay? Someone who is stuck in dorsal vagus, when you're measuring their pulse and you're just feeling for the rhythm, when they inhale, they do not get an acceleration in their pulse. Okay? That acceleration of your pulse is a vagus nerve response. Does that make sense? Okay? And again, you can try it on yourself if you want, or like I said, on a family member. That would be another way that you can assess your client if you don't have kind of the high-tech ways to do it. Okay. Another way that you can do it to test their vagus nerve is that you are going to have them almost like you're looking at someone's tonsils. I recommend using the light on your phone with your client. But essentially, you're going to look at the back of their throat, and every time they say ah, so they're going to open and they're going to go ah, 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 ah. Every time they say ah, the uvula, which is hanging down, the uvula and the pellet on both sides lifts. That's a vagus nerve response. If they are not in ventral vagus safe, when they do ah, 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 their uvula and pellet will not lift. Okay? So that's now, you know, a fourth assessment you could do to measure their stressed out state. Okay, essentially we're just tracking the vagus nerve here. Now, let's say that we notice that they have low heart rate variability. They have high cortisol, high inflammation. Their pulse does not accelerate when they inhale. Their pellet does not rise when they're doing ah, ah, ah. Now you want to get them into a ventral vagus state or a safe. I am safe. So this is a way that you can do it. It's a reset. I'm going to explain it to you, and then on the break you can try it if you want. So you are going to lie on your back. Your client will lie on their back. The hands are interlocked behind the head. And the reason why they're interlocked behind the head is that when you do this, your head does not move. So I'm going to have you turn the eyes, but you don't want to turn the whole head. Hands are behind the head so that the head does not move and you feel that it's not moving. You're lying on your back, and then you're going to take your eyes and look all the way to the right and just keep staring at the right. Keep staring to the right until you either yawn or swallow. Okay? And then you bring your eyes to the center, and then bring your eyes to the left, and you keep holding it and looking to the left until you yawn or swallow. Okay? That is your ventral vagus reset. Now, and you just do it once, right? You're doing it once. And then what I do, Peter, just because you had been asking about it, is I go from a ventral vagus reset. We have one more that we'll do. And then I go straight into diaphragmatic breathing or reverse breathing or box breathing or some sort of breathing exercise. Now, why I like to do the ventral vagus reset first is because just breathing may not activate and get into the diaphragm sufficiently, that we want to first make sure that their vagus nerve is in safety and then do the rest of the breathing. Okay, so that's the first one that we do, right? That's your ventral vagus reset. And then the salamander is another one for stimulating the ventral vagus nerve. The way that you do this is that you are going to start, there's 4 ways. You can do it seated, hands and knees, kind of progressions to the salamander, but you're going to bring right ear to the right shoulder, and then I'm going to look all the way to the right. And I'm just going to hold this for 30 seconds to a minute. And then I go back to the center, and then I go left ear, left shoulder, and I look all the way to the left. Same thing. Then I go to the center, then I go right ear, right shoulder, and I look all the way to the left. And then left ear, left shoulder, look all the way to the right. Okay. There is a full salamander where you're on your hands and knees. I have a video that I'm going to email all of you. So you might be like, I'm not going to remember this. I will email you a video. You're on your hands and knees. And when you bring your right ear to your right shoulder, you actually bend. You can tell that I'm like bending my body, right? So I'm kind of getting all the way like a salamander kind of can bend their body and they move by doing this. That's why it's called the salamander. So you would be on all knees, right ear, right shoulder, and then kind of collapse that way and then look all the way to the right. And that would be the vagus nerve reset number 2. I have it on my note to send you video with those resets. Okay, they're also on the EBFA YouTube channel, but I'm going to send those Vegas to all of you. Okay, great. And then from here, I would go into diaphragmatic breathing, reverse breathing, box breathing, etc. Later into the slides and into the workshop, I go into breathing. And at that time, I will then reference how I focus and put all of the attention into the exhalation, because it's the exhalation of our breathing pattern that drives parasympathetic. So you could do any type of breathing pattern, as long as there's an emphasis on the exhalation, you are then increasing that vagal tone for that individual and getting them into a safe state. Woo, it's a lot. Okay, so I'm going to take any questions that you have on this, and then we will take a short break. Are there any explanations as to the direction of the eyes during this exercise? So yes, so that has to do with a continuation of the muscles and how it relates to the cervical spine. And because your vagus nerve is a cranial nerve, you want to think about cervical alignment and kind of the outlet for all of those cranial nerves. And that's really what it's emphasizing on, is moving those nerves to optimize that for cervical outlet. Okay, great question though. If you want to learn more about cranial nerves, I don't know if anyone has heard of Lois Laney. This is not Superman's girlfriend, but Lois Laney. She has, I'm writing it in, it's called Restorative Breathing. Here, Lois Laney, Restorative Breathing. She specializes in cranial nerves and cranial nerve resets for movement specialists. These are easy things that you can do with your clients, particularly when you specialize in chronic pain, chronic conditions, all of this biopsychosocial autonomic nervous system. Great tips to help get them out of survival. And then the rest of what you do with those clients just sticks better because they're in a state that is ready for what you're going to do with them. Okay. Let me just look real quick here at some of the, Dina asked that when you are doing the ventral vagus reset, does the yawn or the swallow just happen automatically? Yes. And you will actually be surprised on how it just comes. You'll be like, what the hell? Okay, Emily was right that I would yawn. That's a lot of the stuff that Lois Laney does as well, is that she will have you do certain things until you yawn. The yawn is the trigger to the vagus nerve, and it's essentially telling the brain subconsciously, I am safe. That's the way that you want to kind of think of that, okay? With blind people, so to say, it's an eye muscle, it's not a vision. So yes, blind people still want to move the eye muscles. Okay, Lois Laney, yep, dopamine related. It can be. So the lack of dopamine for postural imbalances, dopamine is very complex as far as the emotional processing. So yes, that could definitely be tied in. I would look at gut biome stuff as it relates to dopamine. Whiplash issues, exercises, wearing a neck brace. I mean, I wouldn't do them with someone who has a neck brace. I would leave that one out. I would do the ventral vagus on the back or sitting in a chair for them. And then yes, I will. I'm creating a list of the books that I mentioned, and I will email that as well to everybody, just in case if you don't catch those, okay? Like I said, we could start a book club. There's so many. All right. Any other questions before we take a break? One last question by Peter. Oh, and then yes, there's another question. Okay, 5 questions. Okay. So Peter asked, do I explore trauma as part of my intake? Yes. So I ask about, did they have any birth trauma? Did their, parents raise them? What was the dynamic at home? Were your parents divorced? Do you have a history of any sort of, sexual or emotional abuse as a child? All of that. Almost like a therapist without going heavy into it, but a few key ones to definitely ask if there's some triggers on that. 100% I do ask that. Great question. There was a question. Yes. Dina?
Alrighty, hi. Hopefully you can hear me. My internet is sketchy.
Yep.
So you talked about the postures, so the flex posture, extended postures, and they have all these issues with them.
Mm-hmm.
Let's say they have all those issues, but their posture is fine.
Mm-hmm.
So does that mean like all those things have to be there?
No. So you can have someone who, this is the thing with the body as well that I'm glad that you asked that, is that X never always equals Y. So sometimes these are associations, but they are not definites. But I just want you to recognize patterns with your clients. That if perhaps all of the clients that have the red light reflex, just start to maybe notice and be like, oh, all of those that have that posture carry or have a tendency to be more depressed, or have a tendency to have more of disassociation, which means they have difficulty having body awareness to other things. Like if you say, do you feel this in your glutes? Do you feel this in your quads? People who typically are more disassociated have trouble identifying those characteristics. Like I feel my glutes. They don't connect with their body in that way. Okay, great. Okay, so we are going to take a break in New York. It is 11:45. I don't know where everyone else is, but we will, is a 15-minute break good? A thumbs up, I see. Excellent. Okay, great. Okay, awesome. So 15 minutes, we come back. Ooh, someone is in the UK. Peter, look at you. Okay, it is getting late there. All right, so we will see you again in 15 minutes. Thank you all. Okay, excellent. Welcome back, everybody. Heidi, I think Heidi is on or back. She had typed in a message for everybody related to her experience with trauma and going through polyvagal theory and some of the applications of releasing the trauma, which I think is really important. And I'm so glad that you shared that, Heidi. I am now curious to read some of Deb's work and some of her workshops. So I don't know if Heidi, are you able to unmute yourself?
I am. Here's my face too.
He's like, I don't want to. Can you?
It's so empowering. Instead of this sense of the parasympathetic, sympathetic seesaw, which was what had been my route when I got help from the service, which is fine. They're doing wonderful things. But the polyvagal theory sort of puts you in the driver's seat to be able to have this sense of, I can feel the desire to fight or flight coming on, and I can actually choose to co-relate to the other person instead, or to the situation. So, and I think she studied right with Stephen Porges, and she does wonderful workshops with a wonderful yoga teacher named Mel Burns, who's with Anatomy Trains. So it's great. So good stuff. And I loved your coverage of it in such a short span. That image you had was awesome.
Oh, good. So thank you for sharing that. And similar to, I guess, Deb's work of understanding the polyvagal theory is Peter Levine developed somatic experiencing, which is his approach to release work for those that have gone through emotional and physical trauma, whether it's from career, as Heidi had shared, from being with the military, or it's familial or whatever it is. I think that having those resources to offer to our clients, we don't have to become that specialist, but we guide them and appreciate the role that they have for our clients, and then can refer them to other specialists, which I think is great. Great. So thank you for sharing that, Heidi. And anyone else, if you have other input to add in, please do so. So we're going to jump into, yes, and Peter Levine is great too. So we're going to jump into the second section where we are going to focus on interoception. I'm not sure if you guys have heard of interoception. Again, same thing if you want to type in yes, no. If anyone is new to that term interoception, then this will be very exciting for you. Excellent, great, okay. So why do we have these different experiences and different perceptions? Now, just want to remembering that our experiences and interpretation of those experiences or process to that experience is there or was there to help us survive. So again, baseline, we have to appreciate that and come to it with a appreciation, or our clients have to come to it to an appreciation versus being perhaps upset or frustrated that they are now stuck in fight or flight and just kind of wishing that they had never, gone through that experience, as they should just appreciate their own being as step one. Now, our first experiences are actually introduced in utero. So they're, even before we're brought into this world, we are starting to experience what it means to be safe or unsafe. So this is where, Peter, I do ask as far as early if they can remember or have the question or discussions with their mother of how the birth was. Was it an emergency C-section? Was it full term? Did anything happen during that pregnancy? Was there high stressors going on, from a society perspective that the mother was kind of taking in, because that is essentially being imprinted or influenced on the fetus as well. I love this quote because it's really true that each stress event is singular. It's that moment in time, but that experience that is happening to us in the present moment is a resonance off of everything that happened to us in the past, and not just to us, but to our family, to our mothers. What happened to our mother's mother is essentially represented to how we process things in the present. Now, repression of emotion is a pattern of chronic disease, cancer, and pain. This is very interesting. Dr. Gabor Mate, I don't know if anyone has heard of him or read his book. Dr. Gabor Mate will be in the book club list that I sent to everybody. He wrote numerous books. One of his books is called When the Body Says No. Again, a book I highly recommend to everyone to read because it gives the perception of the influence of emotions and our need to express them, that emotions are energy, we know that, and that if we are not expressing those and they get repressed anywhere within our being, within our physical being, they have to release somehow, and they release in a lot of individuals, unfortunately, in the form of cancer. So he references in his books and in his work that there's actually a cancer personality. And a lot of the cancer personality that he references are those that are like people pleasers, or I have to do something to, please my husband, or I care about my husband over everyone else. You'll actually see this a lot in practitioners such as ourselves, doctors, therapists, movement specialists, because you give yourself so much to others that oftentimes you will give yourself to others as a priority of giving you to yourself, and that is actually a form of this not cancer personality, but it's trying to fulfill yourself through fulfilling others, in a sense, which then can represent itself through, as I had said, chronic disease, cancer, and pain. If you want to read more, please do check out When the Body Says No. Now, what's interesting when we look at children and children's relationships with their caregivers and why we're so imprinted when we're children is that children don't have this capacity to self-regulate. They are essentially learning how to regulate emotions by mirroring their caregivers, whether it's, a mother, father, grandparent, whoever that primary caregiver is. They essentially feed off of their emotional regulation. This means that if their caregiver is not emotionally regulated in themselves, the child will not learn or doesn't learn healthy emotional regulation because of that. And this is how it starts to become multi-generational, because it's learned behavior before we have the capacity to set those foundations of regulation. Now, to kind of hit it home even further, as far as the power of this mother-fetal influences or parent-child influences, here's a couple research studies related to that. So this first study, Monk et al., showed that fetuses with anxious mothers had greater increases in heart rate in utero and matched the pattern of the mother. So if the mother gets stressed, if the mother gets anxious, we know that one of that is a heart rate might go up. They get a vasoconstriction, the blood pressure might rise. You actually see that mimicked into the fetus and the fetal regulation as well. I'm just making sure. How do you feel? Thank you, Heidi. Becomes part of an ancestral pattern. Yes. So this becomes part of ancestral. My apologies. So if the mother is stressed, if the mother is anxious, that heart rate influences and then matches the heart rate of the fetus. Now, another one related to anxious is that Farber found that increased risk of prematurity in anxious mothers, as well as you start to see a shift in the emotional regulation and the motor coordination of those babies as well, which is quite interesting. The last study, Cookson, found that maternal anxiety symptoms was an indicator of stress during fetal life and may increase the risk of developing asthma in childhood. Very, very interesting as well that we start to see this. Now, when you do look at mother fetus influences, is that the mother can actually regulate herself down faster than the fetus. So the fetus will actually continue to stay stressed longer than the mother, which means it's having kind of a prolonged effect on their more sensitive system. The ability for the fetus to then regulate and reset takes longer. So we want to be very mindful of maternal fetus influences. There is a book, another book that is, oh man, I read so many something of the unborn child, emotions of the unborn child. I will be sending it to you. There's several that really focus on when emotions start and when we start to imprint ourselves, and it's a lot of research around that. It's in utero. It's very interesting to see that there is a need to really foster mothers. And essentially a lot of these books focus on and say that as a society, we should be protecting the women who are pregnant from all of the emotional bullshit that might be happening in the world, because they're influencing the next generation of humanity. So, which I agree heavily with, that as much as we can protect that, it reduces what's transmitted to the next generation. And I definitely, for any of the women, I don't know if at any point when you were pregnant, if you would notice that same thing. When I was pregnant with my daughter, as I had mentioned, is 10 months, that there was a period that I remember being stressed, and I brought myself back down, and I could feel that she continued to be stressed much longer than I felt myself being stressed. And of course it freaked me out because I understand these things. So thankfully, she's a very happy baby. All right, so critical periods of development. This is something also that's really important, is that as we go through development, that if we don't either get certain increases in hormones or our stress markers stay a certain way, we can miss these critical periods of development. When it comes to the blood-brain barrier and how we establish immunity and certain emotional regulation, there's critical periods of development after we're born of where your gut biome actually needs to be established. And you have a lot of the bacteria in our gut releases serotonin. And serotonin is like kind of that emotional regulation. A lot of antidepressants are serotonin reuptake inhibitors, SSRIs, and which means that the level of serotonin is important for emotional regulation, happiness, depression, things like that. We have more serotonin receptors in our gut than in our brain, and a majority of the serotonin that we use both in the GI system and in the brain is actually developed in the gut by the gut biome, by our bacteria in our gut, which is a big part of this gut-brain axis. Now, an example of a critical period of development is your serotonin receptors. The number of receptors that you will have in your GI system and in the nervous system is based off of a critical period. So you have this window of where you developed a sufficient number of receptors. And if you don't develop enough receptors in that window, you now have less receptors, which means you might have lots of serotonin in your body, in your gut, and in your brain, but there's not enough receptors to keep you in that ideal mental state. So that's an example of a critical period. There's another one which I will read to you. You guys don't have to read to this. You can just shut your eyes and listen as I read this, because this is really fascinating. So here. The development of sweat glands provides an interesting example of critical periods of development. In the early years, Japanese military took their soldiers to unfamiliar climates. They found that there was a wide difference in the people's ability to adapt to hot climates. Physiological studies showed that this was related to the number of sweat glands, functioning sweat glands. People with more functioning sweat glands cooled down faster. Rather than attributing this difference in the number of sweat glands to genetics, they saw that there was this critical period of development of sweat glands. They found that at birth, all humans have the similar number of sweat glands, but none of them function. In the first 3 years after birth, a percentage of those glands will become functional depending on the temperatures to which the child is exposed. The hotter the conditions, the higher the number of sweat glands that are programmed to function. After 3 years, the programming is complete. The number of sweat glands is fixed. The development of sweat glands encapsulates really what this critical period of development means, and that sensitivity to the environment. I think that that is super fascinating. There are many examples like that in the human body, which is why we also want to appreciate really what is happening in those, let's call it, first 3 years of life. There's another book called The Biology of Belief, which some of you most likely have heard. I see Peter has heard of that. Biology of Belief, which is another one that speaks a lot about this first 3 years. Some people actually say it's the first 7 years, and those first 7 years is how you're establishing pretty much everything as far as, you know, regulation and relationships. So there's this concept that is called homeostasis. Homeostasis is you essentially finding and resetting yourself back to balance. So you find center, balance, things are in equilibrium are some words that you could use. And we have an internal homeostasis. How you feel within your being is an internal homeostatic environment. Now, homeostasis refers to your ability to maintain that stable environment. This could be hormones, this could be your body temperature, this is water balance, this is obviously heart rate and things like that. Now, maintaining homeostasis requires you to continuously monitor that internal environment. With the body temperature as an example, your body is very in a finite regulation around 98.7, is that 98.6, right? So sitting around there, and then any deviation, you either start to sweat or you start to shiver, right? That's your body maintaining homeostasis. Now, if you've ever heard of allostasis, which is similar but different from homeostasis, allostasis is how you maintain homeostasis. So the fact that I'm sweating or shivering is an allostatic response, so I can keep homeostasis. Okay, hope that makes sense. Now, emotionally, there's physiologically, I need my temperature regulated, but emotionally, I need to be regulated as well. Okay, so temperature, physiological, and emotional homeostasis are two important critical aspects to our survival, and both of them are equally important. As I mentioned, allostasis is the response through which we maintain homeostasis. This could be, let's give an example of the emotional side here. So emotional homeostasis is your need to feel safe. Emotionally, you need to feel safe. So let's say I'm starting to feel threatened. Maybe that could be crowds in a room, like a room that's crowded, kind of freaks me out, or an elevator. I'm claustrophobic. So I'm in this elevator, I'm starting to feel claustrophobic. So I start to feel my heart rate go up. I'm starting to feel that I am exceeding my emotional homeostasis. So I go into a survival state. I'm starting to sweat, getting palpitations. I'm starting to get a response. I'm interpreting that response, and I'm starting to freak out. So I go into a sympathetic state, and I respond by flighting, not fighting, but I get off the elevator, right? And then as soon as I'm off the elevator, I'm out of that situation that has thrown off my emotional homeostasis, I'm good. And I calm right back down. I stop sweating. Whew, I feel better again, right? That's an example. So me getting off of the elevator was part of the allostatic response for me to get back into a homeostasis. Okay, so that's a way that you can apply those concepts a little bit broader than just physiologically sweating or, palpitations and things like that. So now survival Survival is based on sensory perception. So your internal homeostasis is based off of sensory perception and your interpretation of that sensory perception, both internally and externally. I'm navigating this environment, but I'm also navigating my internal environment. Both of those environments are necessary for my survival. That is based off of sensory information. The way that I relate to the external environment is through sensory nerves called exteroceptors and proprioceptors. And then the way that I relate to my internal environment is sensory nerves called interoceptors. So I have internal nerves that perceive sensation and external nerves that perceive sensation. Both are necessary to maintain homeostasis and survival. So the external ones, obviously those are the palm of the hands, the bottom of the feet, any of my barefoot stuff that I referenced. It could be hairy skin, it's the light, it's the sound. Proprioceptors are going to be in the joints, and those relate to movement, center of gravity shifts, equilibrium. And then interoceptors will be found in your viscera and in your gut. Now, there's different types of sensory nerves. These different nerves have different rates. So a lot of the somatic nerves, which are motor nerves, are myelinated. So a Golgi tendon organ or a muscle spindle, those are myelinated. Those are referred to as A. So they're afferent nerves. They're a little bit larger. They're myelinated, so they're fast. Okay. Now this is as opposed to a free nerve. Free nerve has no myelin. It's a little bit slower, and it is a C fiber. C fiber. Now let's talk about pain, because this is important. People can have C fiber pain and they can have A fiber pain. There's two different types of pain that your clients are going to present with. Now, when we step on attack, as an example, when we step on attack, we get an initial A fiber response because it's fast, right? You got to get off of the attack. So it's going to use a myelinated fast response. But then you're off of the attack and you feel that kind of slow burning where the tack was, right? So you can still feel it on the foot, and it's like the slower, the one that's persisting. That is the C fiber response to that painful stimulus, okay? So you can speak to your clients and they describe A fiber pain different than C fiber pain. A fiber pain is more sharp. So it's sharp, it's stabbing, right? I'm describing that I have stimulation to my A fiber. A C fiber pain is dull, it's burning, it's radiating, kind of like a toothache, or it's a little bit more broader, right? They're essentially describing C fiber pain. Okay, now a lot of the neuropathies, painful neuropathy, not all, but a lot that I see in my office is more C fiber based neuropathy. And again, not all, because you have to ask for the characteristics of it, okay? Now, when it comes to C fibers and our internal environment that we're referencing, is interoceptors are an example of a free nerve. Other free nerves are, C fibers are free nerves. Examples of free nerves are nociceptors. There's a nociceptor that's a C nerve that's sensitive to pain. Thermoceptors, which are temperature, are a C fiber. And then interoceptors are free nerves, okay? Now, interoceptors, also known as visceroceptors, or some people refer to them as visceroceptors. This is a sensory receptor which receives stimulation from the body, specifically the gut epithelium or the gut viscera, the internal organs, and their fascial web. visceral sensory fibers, interoceptors, travel via the vagus nerve. Hello, here we go. Part 1 is back in session over here. So everything that we had referenced earlier, parasympathetic vagus nerve, vagal tone, heart rate variability, all of those are deeply linked to interoception, okay? Interoceptors are parasympathetic. Okay, so now we have more dots that we can be connecting, or arrows. Okay, so remember 80% of your vagus nerve is parasympathetic, and really what you're perceiving in this parasympathetic interpretation is via your interoceptors. Okay. Now, if we look at interoception, essentially there's a body sensation. I feel butterflies in my stomach, right? So I feel butterflies in my stomach because I'm about to speak in public, and I sense them, but I think that I just ate something bad and I have to go to the bathroom. Like, that's how some people will interpret it. Or there could be, I have butterflies in my stomach because I know that I'm nervous to speak in public. So there's an interpretation. So now we go back to the first slide also. I feel butterflies in my stomach. I sense the shift in my homeostasis. Now I have to label that sensation I feel. Am I going to label that and interpret that sensation as a threat that makes me scared and anxious? Or do I have enough awareness that I know that it's just butterflies and I'll be fine, right? This is where we start to get into that same process of what's happening, okay? Now, we find interoceptors, said that this is your gut fascia, but really within your entire being, it's the fascia, your fascia that we love. Everyone loves to talk about fascia. Your fascia is known as the organ of consciousness, is a way that you can reference it. I also often reference the fascia as an extension of your brain, or it's kind of a brain on its own. It could be like your conscious brain. I know your gut is another brain as well, and your gut is interoceptive. So maybe they all kind of tie in. Your fascia is packed with interoceptors. Now, this is the ratio that you have. Your fascia has 100 million sensory nerves. That's a lot. Of those 100 million sensory nerves, you have a ratio of 1 to 7, where 7 times for every 1 motor sensory nerve, somatic nerve, there are 7 interoceptive emotional nerves. So your fascia, as much as we think of fascia as necessary for movement, so much more of your fascia is actually for emotion, which means that emotion is motion, or motion is emotion. I'm sure you've heard that, right? You essentially influence your emotions with any movement that you do. It also shows the powerful emotional influence that we can have on our being, our body, the power of emotions, the power of the mind on the being. You can kind of interpret it in those different ways. Now, what happens when you essentially stimulate an interoceptor, what happens from a brain pathway is it goes through what's called the interoceptive insular pathway. Your interoceptive insular pathway, essentially your insular cortex. Now, your insular cortex is part of your limbic system. I'm going to show you this again later, but it's part of your limbic system. Now, if I were to say limbic system, what do you guys typically think of the limbic system? If you've ever heard of it, you can type it in or say it. Limbic system is emotions. Great. Yes. Yep. So a lot of people, when they think limbic system, they think emotions. This is the way that your brain kind of processes, is that you go from the brain stem which is the reptile, right? Primal reptile, oldest part of the brain, to the limbic system, which is now our emotional processing center, to the neocortex, which is critical thoughts, language, complex movement, right? So we go through these 3 areas of the brain. Limbic system, emotion. This is part of the limbic system. So you find insular cortex, interoception, limbic system, okay? Now, the insular cortex is where the stimulation goes, and then that's where you put the emotion to it, or the label, the interpretation on it. And then that emotion creates a response, meaning, do I get out of the room? Do I fight? Do I cry? Do I, right? So there's a response that goes through that, okay? Now, why I reference this and why I bring it up is that if anyone is interested in learning more about interoception and what it does for pain, or as we age, or whatever it is, you want to search with that insular cortex. So you would actually want to look at, call it insular cortex activity in athletes. I'm just making this up, but actually I'm not making it up because there is research, but I'm using it as an example. So I just did a webinar on interoception, and I tied it into performance, athletes and performance. And athletes that had the highest insular cortex activity had the greatest mind-body awareness, or interoceptive awareness, that they were able to actually self-regulate, game time fear or anxiety or stress that they would perceive. And some of the athletes that had the highest insular cortex activity were those that played ball sports, because you have lots of stuff going on. So they were able to do very fast executive processing or decision making based off of their insular cortex activity. How you could use this is that when you do dual tasking with your clients as they age, they had a stroke, they have any neurological condition, you probably are doing some sort of dual tasking. You want to increase interoceptive awareness because it enhances executive function. The more mind-body connected, the higher the executive function. You are essentially using the insular cortex to drive cognitive processing, okay? The other thing that was interesting when I was looking at the performance side is that the athletes that had the highest insular cortex activity was actually shooters. So like US shooting, the Olympics, how they have shooting as a sport, or it would be a sport. And the reason is that the shooters essentially shoot in between the breath and almost in between the heartbeat, because when you breathe, you shift. So the accuracy of how they were shooting was actually based off of the fact that they can completely immobilize their body and shoot between a breath and a heartbeat so that nothing is moving. Quite fascinating stuff. All right, so you also see activation, interoceptive activation, not just in the insular cortex, but also in the somatosensory cortex. This means that we are now starting to see the internal emotional perception influences motor output, movement, yes, which is everything that we base on. So the more interoceptively aware, can that start to influence the somatosensory gross motor movement your clients do? Yes. We'll speak more on that in a moment. Okay. So now, why is understanding interoception important for us movement specialists? Why is it important to understand this concept? Internal balance, internal homeostasis, visceral fascia, and what it does for our clients. It's because it influences mood, memory, and movement for our clients. We need to be in internal homeostasis for our mood, emotional regulation, vagal tone, heart rate variability. We need to be in that internal homeostasis for optimal cognitive processing. If we are in survival, you are not having good memory. Your memory gets compromised when you're in survival. When you are stressed and you have perceived stress and your cortisol goes up, it is negative and compromises the hippocampus, which is where we have memory. And then of course, movement gets compromised as well. So all of those three, I will be going through some research in tomorrow's session, 11:30, when I focus on mood, memory, and movement. Okay. All right. So it is time to test your guys' interoceptive awareness. This will be fun. All right. So when it comes to interoception, there's a few ways that you can describe this, and we want to make sure that we are using the right words. With your clients, you can assess them or inquire about their interoceptive sensitivity. What is their interoceptive accuracy? And what is their interoceptive awareness? Essentially, you're asking them kind of broadly, do you notice a sensation, right? Do you notice the butterflies in your stomach? Do you understand that sensation? And then can you manage that sensation? That's ultimately what we're trying to do. When it comes to interoceptive sensitivity, this is subjective. This is you asking them, or you can actually give them a questionnaire, which is called a body perception questionnaire. I will email it to you. How about that? On my list of what I'm emailing you guys. There's a body perception questionnaire. You give it to them. And these are just a few of the questions. Do you notice when you have, tension in your arms and legs? Do you notice kind of that bloated feeling when you have too much water, right? Do you notice when your palms are sweating? Do you notice like subtle sweat that might be on your forehead? Do you actually hear the noises of your digestion? That is interoceptive sensitivity subjective, okay? Now, interoceptive accuracy, now we're starting to get a little bit more objective here, has to do or is measured through heartbeat detection. This is where you do either heartbeat tracking, which is what we're going to do, or heartbeat discrimination. Heartbeat discrimination would be that someone is sitting there and there's music or beats that they hear, and without touching their pulse, they're just sitting there, their eyes are shut, and they feel their heartbeat. Do they feel if their heartbeat is matching the rhythm of the pulses or the beat that they hear, right? Is it in sync or out of sync? That would be a heartbeat discrimination. Heartbeat tracking is what I said we'll do, and this is you sensing your heartbeat, counting the heartbeat, right? Finding how many heartbeats you feel, and then comparing it to your actual pulse. That's the heartbeat tracking. This is where there's a lot of research around interoception around this, okay? We'll do that in one moment, okay? The final layer that you can do with this is what's called interoceptive awareness, okay? This is, I guess, the ultimate in emotional regulation. It would be the awareness of the sensation, but then the management of that sensation. This is where you can then, sense the butterflies, but consciously override and not let the butterflies or your nervousness overcome you, right? Through your perception of the interoception, but then the conscious processing of it. That would be the ultimate level, okay? But let's go to heartbeat tracking. So what I'm going to have you do, I'm going to talk you through it and then we're going to do it, okay? Because we are in a setting like this, I'm going to have you just stay in your chair seated. And what you will do is uncross your legs, or your ankles and legs if they are. And then you want your palms up on the chair or on your lap. You don't want your palms on your legs or on anything, because your thumb has its own pulse. So you don't want to feel that. So your palms are up and you're seated in the chair and your eyes are shut, and you're just going to listen to me for a moment. So with your eyes shut and you're sitting in the chair with the palms up, legs are not crossed, I want you to start to sense your heartbeat, kind of sense your pulse. And when I say so, you are going to count your heartbeats for 15 seconds. We're going to do it 2 times for accuracy. And then I'm going to have you stay exactly as you are, but you will take one hand over to the opposite hand and find your actual pulse and feel that pulse. Okay, and then we will count your actual heartbeat for 15 seconds, 2 times, and then we will compare. Okay, so I'm going to give you a moment to keep your eyes shut, palms up, to find and start sensing your heartbeat. And start counting. Stop. Stay exactly as you are. We're going to do one more. Start. And stop. Good. So now take your hand over to where you have your radial pulse. Find your actual heart rate. And start counting. Stop. One more, please. And start. And stop. Beautiful. Okay, so you will open your eyes. And then what you're going to do is you're going to take the lower number divided by the higher number and find your percent accuracy. So let's say if you sensed 16 beats, as just an example, and your actual pulse was 18, that's actually high, so, right? But 16 divided by 18, call it 85% would be your accuracy, right? Your interoceptive accuracy or your heartbeat accuracy. And then we want to understand what that means. So if you find your accuracy 80% or higher, 80% or higher, that would be considered a high interoceptive accuracy. If your number is 60% or lower, 60% or lower, that would be a low interoceptive accuracy. Right? So you're just kind of finding where that is. If you were 100, awesome, great job. That's over 80. Okay. Now, what you may start to see is that you will have your clients and you're getting them set up like this, and you say, okay, now I want you to sense your heartbeat. Your clients may say, my what? How am I going to feel my heartbeat if I'm not actually feeling some sort of pulse, right? You will hear that. That is someone that you're starting to think, okay, what is their interoceptive awareness? What is their mind-body connection to the subtleties of their internal homeostasis? And is this perhaps a sequelae of them disassociating from their body because of, something that happened in their past or in their life? So what I need to do is make sure that I'm starting to get them back in touch with their body, increase their mindfulness and their mind-body connection, bring kind of forward the importance of interoceptive awareness, and then how that translates to the way they carry their body, their emotional regulation, their movement, their balance, etc. Okay, so that is interoceptive accuracy based off of what's called heartbeat tracking. Now, one thing that you can have when it comes to interoceptive sensitivity or interoceptive accuracy is you can have some people that are hypersensitive, or hyper monitoring their internal environment. This would be, as an example, someone who has more anxiety, panic attacks, PTSD, because they are so vigilant. They're in a hypervigilant state for survival that any subtle shift in their internal state becomes like an alarm, right? So the alarms get turned on too quickly, in a sense. And individuals like that often can have an increase in pain sensitivity. So we want to be interoceptively aware, but we don't want to be interoceptively hyper aware or hypersensitive. I see that in my patients when they get like super worked up when I need to give them an injection. And I know that that's going to be the patient that if I don't take measures before, they will pass out when I give them an injection because they're getting themselves all like in a tizzy. So I start doing breathing. I, start to lay them down. I start talking to them. I get them present in the moment. I have to, right? That could be kind of a similar example of what you might notice with some of your clients based off of their day, their presentation, etc. So this is just a chart that breaks it down. You can see one of the research studies, just in case if you want to look more, but it breaks down interoceptive accuracy, sensitivity, and awareness. Sometimes these words are interchanged, so you just want to make sure that you are using them the right way, okay? Now, we are not going to take a break. I think I'm going to continue through, but I do want to take any questions that you guys might have related to this. Oops, I did not mean to come out of that. Any questions on interoception, interoceptive accuracy? So now when it comes to how you increase someone's interoceptive awareness, your assessment becomes your exercise, just like a lot of stuff that you do. So the heartbeat tracking assessment that we did, use that to actually increase interoceptive awareness. This could be as simple as saying, before you go to bed, when you're lying down, or when you first wake up in the morning, just stay there for a moment and feel your heartbeat. Maybe how you might tell them to do a breathing exercise, a couple times a day when you first wake up before you go to bed. If you're stressed out, you might have them do box breathing or 360 breathing or something like that. This could also be just sit there, shut your eyes, and try to sense your heartbeat. And that heartbeat tracking exercises, there's some research that you can find as a way to manage stress and depression. And there's a few research studies out there that show interoceptive training can actually get people off of anxiolytics and antidepressants. So it's something that you could use that way as well, which is great. Can interoceptive measures detect more chronic conditions such as suicidal ideation or clinical depression? I think that it definitely plays a role, right? So if you're seeing kind of the level of disassociation. So suicidal ideations are typically, you would see that in parallel with depression, which would then lead to disassociation. The more in touch you are with yourself, the more, remember that interoception is vagus nerve, And the higher the vagal tone, the higher the emotional regulation. Yeah. Now, will tinnitus interfere with this? It shouldn't, because it's more of a visceral perception versus anything up here. So the tinnitus should not. However, you may see a reduction in the tinnitus the more interoceptively sensitive or in tune you become. So you may find a benefit from that. Yes, will caffeine affect this assessment as far as the heart rate? Yes, you always have a higher heart rate with caffeine, or a lot of people who are sensitive to caffeine, it will increase their heart rate. Same thing with beta blockers, where a beta blocker affects the heart rate. And then other medications, some anxiolytics, others will increase the heart rate. What you're not looking at the interoceptive accuracy from, are they at a healthy heart rate or not? It's just more, can you actually feel your heart rate is the baseline. So if you have a fast heart rate, maybe we need to address that, but can you even perceive that your heart rate is fast? Right, so it should not change the perception of the heart rate if you're on caffeine or a beta blocker. Yeah. Jamie asks, can interoception training help a client cope with PTSD? 100%. 100%. Yes, that's actually one of the categories that it is. You can find any of the mindfulness exercises that are done, let's say with like a war vet or other you know, domestic violence or other characteristics where you might see PTSD. That's where you want to start looking at some of that research. There's not a lot of interoception research in traditional fitness. So you guys incorporating it now into your practice is actually ahead of where a lot of people in the industry are. Interoception is classically still percolating within psychology and mental well-being. So you will find body workers who work with trauma will be very in tune with interoception, but not necessarily a trainer unless they're introduced into that world, as you guys are now introduced into that world. Yeah. Okay, great. Any other, let me see if there's any other questions that I happen to miss. So Heidi suggests a book called How Do You Feel by Bud Craig. It's a book on interoception. So if you're interested in learning more about that, that's great. So essentially interoception, the big takeaway of how we start to connect block 1 with block 2 and biopsychosocial is you have a client. Let's start to tie this in a way that we can use this in our practice. Is you have a client that you're trying to reduce their falls, okay? And they have a history of falls. Maybe they've fallen once, but with every history of falls, you now have this layer or complexity of a fear of a subsequent fall or a future fall. Now, what I encourage you to ask yourself is that when you're doing fall reduction training or programming with a client or a group of clients, is understand the emotional layers that go into fall prevention. If they have a history of falls, you want to understand the characteristics of that fall. If they fell, did they get up right away? Or were they on the ground and couldn't get up, so they felt more helpless, but also how long were they on the floor for? If someone falls and they can't get up and they're on the floor for a longer period, they now start to interpret that threat from a different perspective. if they felt like they were on the floor and they couldn't get up and no one was going to help them, they could have shifted into the freezing shutdown response, where someone who could get themselves back up got into the fight or flight. They were able to mobilize themselves. So they mobilized and got themselves up. So I want you to understand that that's how you can start to see this in people's differences in the response to falls. And their awareness to that may not even be on a conscious level. Most of them probably do not perceive the complexity of their fear of falling on future falls. So please make sure you are asking a very appropriate fall history questionnaire that relates to some of that emotional interpretation of that fall. And then you will want to start to build in the interoceptive awareness of that fear when they start moving again, and how you can help them to regulate that. And which goes into the third and final block, is how we can use sensory stimulation to help them feel safe exteroceptively while we are trying to build safety internally. Okay, so now we're going to be talking about exteroception and that aspect of sensory input. If you remember that slide that said survival is based off of sensory stimulation, both internally and externally, you need to control both environments to feel safe and to survive. It's easier for a lot of people to use external sensory because it's sometimes easier to perceive because I can touch it. I can touch this ball, right? Or I have all my Naboso stuff here. I can touch the Naboso insole, so I can perceive that much easier than if someone is telling me to sense my heartbeat. Yeah. So I like to use exteroception as the transition point into interoception. First, help them to feel safe externally, and then let's bring it in internally. Okay. Any other questions? Do we need another bathroom break before we go to the last block? Yes or no? I will take the silence as a no. You're good, keep going. Okay, so if you do have to step away, you're good. Okay, great. So we go to approximately 2:30. I know some of you are in sessions that start at 2:30. So I do want to make sure I give you a little bit of a transition period and ensuring that we cover all of the content. So please remember to ask questions if you need those. Use breaks if you need those, hydrate and eat as you need. All right, so how are we beginning to apply these concepts of biopsychosocial as a movement specialist? How can we start to build this into our practice as a lens through which how we look at our clients and some of their conditions that they present with? So you can start thinking of biopsychosocial influences when you have some of these characteristics in your clients. They may be a perfectionist or type A personality, typically has a little bit more of a psychosomatic tendency. Again, these are not all A equals B, X equals Y, okay? Does your client suppress or stuff down negative emotions? Remember Dr. Gabor Mate's work and the book that Body Says No, that Cancer personality that I'm sending you, that is a characteristic as well, as the suppressing of negative emotions. We want to express ourselves, okay? Think of that as energy that is being released from the body. Think of that similar to how you have a threat and then your body wants to shake. The energy has to be released. Does the client have a history of verbal, physical, sexual abuse as a child? You will want to have maybe just a quick trauma questionnaire. I often find that certain sensitive questions I have as an intake form that they fill out versus me asking questions. So it's based off of the trust that your client feels with you to open that stuff up, or for them to realize that it's important. I think that I'm sure you've had some clients where you're like, have you ever had surgery? And they say no. And then 2 minutes later, it comes out, oh yeah, when I had my right knee replaced, and you're like, okay, that's surgery. Why did you not mention it? They don't connect it always, right? But I always ask patients about like their sleep and their stress, and they're like, you're a podiatrist, why does that matter, right? But everything matters. So somehow they need to understand that it does matter, but they also have to trust you. So maybe having it as a questionnaire versus you asking them. Now, how is your client's sleep? If you don't ask about their sleep patterns, some things that I ask about sleep intake is obviously the time, how long, if they use any monitors to know how often they're in deep sleep versus kind of that superficial sleep versus REM versus which wavelength are they in. You can get really detailed on that through things like the Oura Ring, and other kind of tech that they would wear. Or even the apps, there's a sleep app that you can get that they can just use. I also ask as far as lighting in the room, temperature in the room. What I would do is kind of encourage them or educate them on the sleep environment, because sleep is so important. Make sure you're finding out the temperature of the room, the lighting. Do they use any blue screens before? If they do, make sure they're turning them to red screens. And then from a movement postural perspective, is I always ask them what position they sleep in. And if they wake up halfway through the night, what position do they find themselves in? Do they have, the right leg up or the right leg externally rotated? Are they in a fetal position? Things that help you to understand, like, oh, no wonder your right psoas is tight. You're always sleeping with your leg up in a certain way, or, you're on your stomach. Oh, so no wonder your QLs are tight. Kind of helps you from that perspective as well. Any marital issues, that's obviously a stressor. Do you have elevated shoulders? Are you bodyguarding? Do you grind your teeth or clench them? Definitely something to ask versus just thinking they'll come up with that. Any dysfunctional breathing? Do you hear them breathe? Do they snore? Do they have GERD, acid reflux? All of those contribute to a biopsychosocial. Now, some other key ones that we want to remember is that postural imbalances can reflect that autonomic nervous system state. Remember the red light reflex versus the green light reflex. I'm going to send you a book called Somatics that is based off of. So you can learn more about red light versus green light reflexes. That is telling you posturally about that autonomic nervous system state. Breathing patterns, Peter had typed that in earlier as far as you can watch them breathing. Are they in a supradiaphragmatic or a subdiaphragmatic breathing pattern? And then that's you interpreting that state. Now, before you do any of the breathing, I like to bring them back to the ventral vagus state. That's the salamander, that's the hand behind the heads, and the eyes are turning, waiting for them to swallow. That's important. You want to check their stress state or their ventral vagus state, the pulse and the uvula, so remember that. And then remember the salamander exercises. I'm going to be sending you a video that shows you again how to do those. And then the last thing that's interesting is spinal nerve issues are different than cranial nerve issues. Cranial nerves, like a ventral vagus reset, is different than like if someone has sciatica and you do a nerve floss and you open up the hips and you do a figure 4 and stretch the piriformis. They present very, very differently. So if you are curious to delve into this more, I do highly encourage you to look at Lois Laney's work and restorative breathing. Her specialty is cranial nerves. Cranial nerves, different than, like I said, I have low back pain. I have a radiculopathy in my arm. Those are spinal nerves. Okay. So this is where we want to start kind of going into that reset with our clients. Is step one is you want to build that somatic awareness, the interoceptive awareness, the breathing, the listening to the heartbeat. And then step two is reconnecting through that breath, the box breathing, the exhalation. I'll reference those again in a moment. And then Heidi had mentioned this with her movements that she did, some of the sling work, which I'm not familiar with sling work, but there's somatics is a body movement. Dance is an emotional expression. She had done slings, which is emotional expression through movement. Remember, when you move, you influence fascia. Fascia has a 1-to-7 ratio of emotional nerves compared to motor nerves. So you want to get them moving. Somatic intelligence, yes, perfect. So Peter had called the somatic, or the movement, is somatic intelligence. Absolutely, I think that's a great idea, or a great name that we could give it. So now when we look at breath work, because breath is critical to anyone that we are thinking biopsychosocial influences, the way that we breathe is really an interpretation of our internal perception. So if someone is stressed, you can always see that through their breath. Their breathing style, their breathing pattern is very much connected to that stress state. Remembering that their stress state is based off of their interpretation of that internal perception. Yeah, so it gives you an idea of their interoceptive state. Okay, now that breathing pattern links to diaphragm function, links to stability. So if you're trying to reduce someone's falls, let's go back to falls. If you're trying to reduce someone's falls, they need to have balance, right? They need to have center of gravity balance. They need to be stable with their being in gravity, in this gravitational space. They need to be stable, but they're only as stable as their core muscles, diaphragm, are stable. So if someone's not breathing the right way because of poor interoceptive awareness, now their diaphragm doesn't work and their pelvic floor and their whole center is not stable. So you can for sure connect it that way as well to reducing falls. Breathing is diaphragm. Breathing is safety and interoceptive interpretation. Diaphragm and breathing is pelvic floor stability as well. Okay, so we can take it even further. Okay, now when it comes to breathing styles, these are a couple ways you can break it down: above the diaphragm, below the diaphragm. Above the diaphragm is survival breathing, or here it's called sympathetic breathing. Below the diaphragm is parasympathetic, or your safe breathing. You can also consider above the diaphragm as allodynia. So when someone is breathing in a very shallow breathing, they have that increased sensitivity to pain. I know you guys deal with a lot of chronic pain clients. When you have subdiaphragmatic, or that restorative breathing, you can actually call it analgesic breathing. This is where, when I'm about to give an injection to a patient, I have them breathe subdiaphragmatically, because they actually don't feel the injection as much as if they were freaking out and breathing supradiaphragmatically. Couple comorbidities when it comes to breathing patterns and diaphragm function: acid reflux, right? If someone is taking proton pump inhibitor, Zantac, things like that, you want to start thinking stress levels, diaphragm function, breathing patterns. You can hear them breathe, sleep apnea, they have a deviated septum, they're a mouth breather, they have urinary incontinence, is getting into the pelvic floor, and then pain during sex, both male and female, is a classic pelvic floor presentation, which makes me start thinking about diaphragm as well with those patients. So now diaphragmatic breathing, I'm sure you guys are all aware with diaphragmatic breathing, or three-dimensional breathing is how I call it. You can do it on your back. What I will do is give you a few pearls of how I do it. And if you want to join me in the breathing, you absolutely can. I like to call it 3-dimensional breathing because I have them focus on three key points as we're going through the diaphragmatic breathing. A lot of people that I find, and I'm sure you find as well, is that when you have them put a hand on their chest and on their abdomen and you tell them to breathe into the stomach, the chest is still rising. Do you guys ever notice that? Right? So you know that they're not fully diaphragmatic breathing or sub-diaphragmatic breathing. So that's why I like to use the hand on the chest and the hand on the abdomen, because they will still cheat or fall back into that pattern of breathing supradiaphragmatically. So the first cue that I give is to focus on the belly rising, right? That's the first dimension, is that every time they inhale, the belly rises, okay? Now the next dimension is that every time they inhale, they should feel the rib cage expand, right? Laterally and posteriorly. So they feel that dimension, okay? And then the third is that they want to feel the pelvic floor go down. That would be the third dimension. So as they sit there, if their eyes are shut, they can feel, okay, my belly is rising, okay, or I feel my rib cage expanding, or when I inhale, I'm breathing down into the base of my pelvis. You want to allow the pelvic floor to relax and expand so that it can come back up when they are exhaling. So you find the pelvic rhythm as well. So the 3-dimensional breathing. So here's the diaphragmatic breathing. When I set them up on their back, this is some key cues that I give. So step 1 of the body position for diaphragmatic breathing in a chair or on the back is to align the rib cage and the pelvis. So that's my step 1, stacking the cylinders. And then you're comparing the chest to the abdomen. Of course, we want the abdomen. 3-dimensional breathing. And you want to make sure that they are relaxing any of the hip flexors or global muscles. You don't want to feel anything that is engaging. Now, the end range expiration, we want to remember that if it's the inhale or the exhale, it's the exhale that's creating the response on the autonomic nervous system. So dragging out the exhalation is having the effect on the parasympathetic system. It is also a pelvic floor activation. So if someone is having a very hard time engaging their deep core and their pelvic floor, just doing end range expiration will activate the deep core muscles. With the end range expiration, you want to start by inhaling. I inhale for 4, exhale for 4. Inhale for 5, exhale for 5. Inhale for 4, exhale for 8. Inhale for 5, exhale for 10. So I'm essentially kind of warming up the diaphragm muscle and then go into the end range expiration. When you are doing the exhale, you want to, and you're going through the end range, which is the exhale, 8, 9, 10 seconds, right? You want to have an awareness into the pelvic floor and the deep core muscles. Anytime you engage the pelvic floor, I like to keep it around 25% of max contraction. I will give as a bonus, I'm not referencing it here with the foot to core sequencing, but in EBFA's education, we focus a lot on grounding and having your feet connect to your core, connect to your diaphragm. So we essentially stack those 3 domes in the body. What you can do when you're seated, and we can even kind of play around with it a little bit now, is that if you're seated or you're on your back, when you exhale, as you are exhaling, I want you to gently connect your toes into the ground. Yeah? I feel like we should do that. Like, it'll just be fun. Let me do it. Let me do it with you because it'll be lots of fun. Okay. So if you are in your chair, we'll play my game with me. I'm going to have you scoot to the edge of the chair so that your feet are flat on the ground. If you have shoes on and you are in your home, shame on you. I'm just kidding. But I would encourage you to be barefoot in your home. So you are on the edge of your chair with your feet flat on the ground. If your feet have no socks on them and you're barefoot, it's a little bit better because you can actually feel the dexterity of the digits and you can feel the ground. And I want you to start, you're going to shut your eyes as we go through this. You're going to stack your rib cage and your pelvis. So just stay stacked, and then bring one hand to your chest and one hand to your abdomen. And now your eyes are still shut, and I want you to just kind of wiggle your toes. You can, crinkle your toes, spread your toes, and then feel the toes on the ground. Your eyes are still shut and your breath is relaxed, but just start to feel the ground underneath your toes. What I'm doing by saying this is I'm essentially anchoring your nervous system, or I'm trying to use touch to build safety to your nervous system. So you feel the ground. If you had a Naboso mat, I would tell you to feel the texture of the Naboso mat, connect to the texture, connect to the ground. And now I want you to inhale into your belly. So feel the belly rise. And then exhale, feel the belly come in. And I like to do it all through the nose. Again, everyone has their own technique. So I'm going to have you inhale, exhale through your nose. Inhale again. And exhale through the nose. So stay exactly as you are. Keep the hand on the chest and the hand on the abdomen. You want to really focus on how the abdomen is rising every time you inhale. And then as you exhale, you want to feel the abdomen coming in. You can stay exactly as you are like that, or if you want, you can move your hands to your rib cage. Inhale in through your nose, still feel the belly rise, but start to feel the rib cage expand. And then as you exhale, feel the rib cage coming in and the belly coming down. Good, do one more. Inhale. And exhale. You can keep your hands on the rib cage. You can move it back to the hand and the abdomen. This time as you inhale, I want you to focus breathing down into the base of your pelvis. So inhale, belly rise, rib cage expand, down into the base of your pelvis. And then exhale, belly come in, rib cage come in, pelvic floor rise. Do that one more time. Inhale, belly, rib cage, down into the base of your pelvis. And then exhale, belly comes in, rib cage comes in, pelvic floor start to rise. Now you can stay hands where they are, hands, chest and abdomen, or rib cage. We're going to do just a couple repetitions of the end range expiration, and we're going to focus on the feet. So I'm going to have you inhale when you're ready. Inhale through the nose. Feel the belly rise. And then start to exhale. And as you exhale, just keep exhaling, full exhale, all of your lungs exhaling. Keep exhaling. Start to connect your toes to the ground. As you exhale, just feel the ground, feel the toes. Maybe start to connect the toes. And then good, release. Inhale when you're ready. Your belly should just rise. The inhalation is a reflex to the exhalation. And then when you're ready, start to exhale again. Belly comes in, rib cage comes in, pelvic floor rise. Connect your toes to the ground. Keep exhaling, keep exhaling, keep exhaling. Feel the ground, feel the toes. And then release. Inhale. Again, let it be a recoil or a reflex to the exhale. One more time. Start to exhale. Last time. Toes are in the ground. Keep exhaling. Feel the pelvic floor start to rise. Keep exhaling. Feel the abdomen coming in. Exhaling. Start to feel that foot core connection. And then good, release. Beautiful. Okay. So that's the way that I use that as a way to, yes, I'm getting you into a parasympathetic state, but I'm using touch to bring in this safety. I'm grounding, I'm anchoring. Use any of the words that you want. You doing that either at the start of a session, at the end of a session, you teaching your clients to do that on their own. If they start to feel, pain, let's say, or they're starting to feel that they're losing their homeostasis, just ground yourself, right? Ground yourself through your breath. But could we bring touch into how we ground ourselves? If you don't want to have your hands here, you could have something in the hand, have the hands on the table and just feel, have your hands holding something and just feel as you're going through it. Some people will do, you know, a fist if you want. It's up to you on how you want to bring that stimulation in from a hand perspective. I like to ground through the bottom of the foot and touch as that anchor point. Okay. And then again, end range expiration is the exhale that is resetting the parasympathetic state. It's the exhale that's activating the pelvic floor. So technically now their deep core stabilizers are stable. When you push your toes into the ground, you technically are activating the intrinsic muscles of the feet. So deep foot connects to deep core. So we have a autonomic nervous system balance, we have a fascial balance, we have a foot to core balance. All of these are layers of how we want to build technically a fall reduction program, is with those layers. So now let's bridge interoception with exteroception to enhance safety. Okay, so now touch, palms of the hand, bottom of the feet. Touch in general is cholinergic. Cholinergic. Have you guys ever heard the term cholinergic? So cholinergic in your mind will mean activating, is how I want you to think about that. Okay. I'm just seeing if there's any quick crocodile breathing. So you can absolutely do crocodile breathing, which is what Dina have referenced. And then Peter's Western not a breathing culture, distinct from others. Yes, we're stressed out here, Peter, in the US. As he looks at us from across the pond. Cholinergic will mean activating. Okay, it's a term that technically is referencing the upregulation of acetylcholine. So acetylcholine is a neurotransmitter. It's a neurotransmitter that is used by our muscles to contract. It's used by our heart rate. It is used for many aspects of physiological regulation. So cholinergic will mean waking up or activating, okay? If we look at our brain again, there's part of the brain, it's the brain stem, part of the brain called the reticular activating system, or the RAS, reticular activating system. This is part of the brain stem that is, it's kind of like the ignition to the brain. It has to be turned on in order for us to process things, remember things, learn, okay? So all aspects of human optimization and client programming is based on the RAS. Yeah, so if we are offline, we're not going to process things well, we won't learn. So to wake up the brain and get it ready for the session, let's say, you want to stimulate via cholinergic pathways to turn on the brain. Touch is one of those, okay? Your reticular activating system, which is part of your brainstem, regulates wakefulness and sleep-wake transition. So again, it's that ignition, okay? It connects the midbrain to the neocortex through the thalamus. So these are, I'll show you these in a minute. Okay, we must be awake to learn, remember things, control our emotion, and move, okay? So how do we wake up our brain? Touch is the first way. But your reticular activating system is also connected to your eyes and your ears. So your eyes and your ears can turn on your brain. This is where eye movement exercises are something that is great to prime the brain for the session you're going to give your client, the exercises, the new lesson you're going to teach them. Now you could do eye movement exercises. However, if you stimulate your tongue ligaments, so when you yawn, your tongue goes to your palate, right? So you're yawning, you're stimulating the tongue ligaments. Your tongue ligaments connect to your vestibular system, and the vestibular system connects to the reticular activating system, right? So that's why people yawn, not just when they're tired, but when their brain is starting to get sleepy, right? Not tired, sleepy, but like processing sleepy. So it's a natural response of the body to wake up the brain. Now, another thing you can do is just bring the tongue to the palate, is something that I actually do with clients and patients. Tongue to palate, same way, we'll stretch those tongue ligaments. You don't have to yawn. Or you can rub outside the ear here. This is actually an acupressure point that connects to the reticular activating system. Your vestibular system and your ears are a system that is in response to gravity. We reduce falls and maintain our balance in space as it relates to gravity. So your vestibular system, someone was referencing tinnitus quite a bit, that the vestibular system and how it relates to gravity is critical to how we orientate in space. So your vestibular system connects to your postural system. It actually connects to your core. So training the vestibular system activates core muscles, because those are posture muscles. That's how you navigate in space. It also obviously stimulates the reticular activating system, eyes, eye movement exercises, touch. Okay. So this is found in the brainstem, the reptilian brain. This is the lowest part of the brain, the oldest part of the brain. The focus of the brainstem is survival. Remember I said that. So your autonomic nervous system is actually part of the brainstem. Okay. When someone is stuck in survival, they're stuck in their reptilian brain. So they can't go forward into learning things and remembering things. The limbic system, this is what we had referenced for when it was with the interoception, right? So limbic system, emotion, interoception, this is where it's processed. Another key aspect here is not just emotion, but motivation. Now, I know with a lot of your clients, motivation becomes really important. And I don't know if some of you have kind of that key aspect of how do you keep your clients motivated? A lot of people with chronic conditions, diabetes, Parkinson's, MS, stroke, the motivational element is really important for them because they actually have what's called central nervous system motivation, or a deficit in central nervous system motivation. Okay, there's we'll call it peripheral and central motivation. Peripheral would be kind of like, come on, Emily, like, let's go to the gym, like, let's psych it up, like willpower, like that's kind of a extraneous motivation of how you keep your clients committed to losing weight or staying on track with a fitness goal. Whereas central nervous system motivation is actually built within the synapses and the chemistry of the limbic system in the brain. When we get chronic neurological conditions, you start to lose some of that neurological side of motivation. Why I reference this is that if you have a client with, let's say, Parkinson's, and you have a hard time keeping them motivated, part of it is not their fault. So coming at it with a patience and an understanding versus a frustration to their lack of staying motivated, I think is really important because it is part of the disease. A lot of neurological central nervous system diseases have central nervous system deficits in motivation. Right? Diabetes is another one. The glycation and oxidation of the nerves that affect the peripheral nerves and the kidney and the retina of diabetes also affects their central nervous system, and they get true central nervous system deficits in motivation. It's not their fault. It's really a sequelae of a lot of these diseases. So it's, like I said, coming at it from a patience or compassionate side goes a long way for them. Okay. When we break down the limbic system, we can break it down into the thalamus, the hypothalamus, basal ganglia, amygdala, and hippocampus. Again, this is where we find the interoceptive system. I'm not going crazy into these. I did it last year at Functional Aging Summit, and we have some webinars, and our BTS level 1 goes into these. But I just want you to see where it breaks down in the different subsections of the limbic system. The amygdala I had mentioned, that's heavy emotion. When someone is just kind of riding off of their amygdala, they are reactive. Oftentimes that is due to stress. Hippocampus is our memory. Hippocampus is affected by stress levels. You actually get a denervation of the hippocampus when stress is too high. So then memory gets compromised. There's some interesting research that looks at PTSD and memory and actual denervation of the hippocampus in PTSD patients or individuals. Now, one of the best ways to upregulate hippocampus new synapses or new nerve regeneration in the hippocampus is exercise. So exercise is very neuroprotective, as we know, but I want you to also appreciate that it is hippocampal protective, which is your memory center. All right, so now finally, the last part is the neocortex. This is where we find our somatosensory cortex. So the somatosensory cortex is really the motor cortex, the movement. Somatics is movement, muscle, right? Sensory in, motor out. This is where we find our beautiful homunculus. And the homunculus is our relationship to the external environment as it relates to exteroception or external sensory processing, where the interoception was the insular cortex, insular environment, visceral nerves. This is exteroceptors, external environment, somatosensory cortex, okay? And then of course they cross each other. Now, the areas here that are the largest, of course, are the greatest that are represented in the brain. Hands and feet are what we're going to focus on. This is referred to as glabrous skin. So hands and feet have the mechanoception or the touch. Touch is cholinergic, remember. So touch is how we can build safety in our clients and reconnect them to their own body as it relates to the external environment. Now these mechanoceptors, these are different than proprioceptors, which are different than free nerves. Remember we said there's A fibers and C fibers? Remember that was earlier, A fibers, C fibers? A fibers, myelinated. A fibers are somatosensory. On this left column here, this mechanoception, proprioception, those are somatosensory. C fibers, free nerves, are nociceptors, thermoceptors, and interoceptors should actually be down there as well, okay? Different types of pain, different types of disruption. You can have different types of neuropathy. Some people with neuropathy can have A fiber deficits, and some people with neuropathy can have C fiber deficits, okay? We spoke a little bit about the interoception and the C fiber, so we want to go on the other side and look at mechanoception and proprioception, okay? These mechanoceptors are our touch receptors, which are what's on the hands and the feet, okay? This is how we are understanding what they are sensitive to. They're sensitive to 3 primary stimulation, and you understanding this allows you to bring in that stimulus to shape their programming. Now we can think of this in 2 main classifications. When it comes to mechanoception, hands and feet, they're broken down into 2 main speeds, the way that they respond to stimulation. You have slow adapting and you have fast adapting. The ones that are slow adapting are constantly reading the environment. The ones that are fast adapting respond to a stimulation and then shut off, okay? So when we stand in one place, which is what's called quiet stance, and this is where you're assessing in your client's sway. So if you ever assess medial lateral sway in your clients, right, like a Romberg test is kind of a sway test, you can measure how much your client sways, just quietly standing there. The larger the sway, there's a direct correlation to fall risk. So you could see the more they sway, like, okay, this client has a little bit more fall risk. Sway is controlled by slow adapting nerves, the SA1 and SA2 that's on this slide right here, okay? The fast adapting ones are more when we're like dynamically moving, okay? Now, the first SA1 nerve is texture or 2-point discrimination. This is the Naboso product line for anyone who's familiar with the Naboso product line. It's essentially a 2-point discrimination mat or insole that I did develop, so total, you know, disclaimer there, that I developed to stimulate the SA1 Merkel disc nerve. The other product that's similar to this would be Braille. So anything that has Braille is stimulating SA1, texture. But texture is really 2-point discrimination is what you want to say. The second one, SA2, is skin stretch. So when you stretch the skin, an example of skin stretch would be kinesiology tape. I don't know if anyone uses that with your clients. So rock tape or K-tape or any of those. K-tape and rock tape and different taping strategies use skin stretch or the SA2 receptor. Your SA2 receptor is also found in your fascia, like your myofascial web that's part of your body. You find SA2, okay? Now, when you stimulate SA2 or skin stretch, you downregulate the autonomic nervous system. So you bring someone into a parasympathetic state. This is what massage does. So when you do massage, like a slow body massage, so not like deep pressure and all that stuff, slow body massage is you allow the stimulation of the SA2 receptors, okay? Now you can do that also with foam rolling. So foam rolling is a way that you can start to bring in some sort of skin stretch, especially some of these rollers that are made of silicone. So they stick to the skin and you actually get traction. So I like silicone type products for that reason. So a way that you can start to kind of use some of this information. And aside real quick is that touch being cholinergic, touch activating the reticular activating system is why I also like foam rolling, Lucy's at foam rolling in the start of the session, because touch could be you touching something, but it's also something touching you. And because there's all this whole like, don't touch them, can you touch, ask them to touch, like touch just gets weird, is they can foam roll their body, and that's essentially touching their body to activate it for the session. So it's a way that I like to use it. Same thing with dry brushing. So I like to have clients or patients dry brush. Obviously, I'm not always seeing them in like a gym setting, but I tell them every morning to do dry brushing because it's stimulating the brain and their touch receptors. It's a way to influence the autonomic nervous system, and just the nervous system in general is, let's turn all the lights on. So we're going to dry brush because touch is cholinergic, right? That's the way that you could do it for them. Now let's go real quick into the fast adapting. Both FA1 and FA2, you can see here, are sensitive to vibration, okay? Now, vibration receptors are not just in our hands and feet, but these are also in your myofascial web. All over your body is sensitive to vibration, okay? We experience vibration as ground reaction forces. So anyone who's listened to any of my lectures about why I'm a proponent of barefoot movement and am anti-cushion in shoes and all of that stuff is because foot-ground relationships are vibrations. And the foot striking the ground, creating vibration, stimulates your entire myofascial web through the FA1 and FA2 receptors, which tells your body where it is in space and feeds the load and unload response of the body. Another thing when it comes to vibration receptors is these fast adapting vibration receptors actually make up 70% of the nerves in the bottom of the feet. So they're really, really important to how we maintain our relationship with the ground. And we also use vibration to maintain our balance. So vibration feedback helps us to maintain dynamic balance. So fall reduction. Fall reduction programming needs to be aware of vibration forces that are coming in, and how can you optimize your client's perception of that vibration. Get the cushion out of shoes is a way to do that. Yeah. Whole body vibration platforms is another way that you can do that. So we want to make sure that we are being sensitive to these input systems. Okay. If anyone uses Power Plate, which I know is a partner through Functional Aging Institute, I have a Power Plate in my office. I like Power. I've actually created a lot of programming for Power Plate, so a little bias there. That whole body vibration / Power Plate is great for clients because it stimulates the vibration receptors, which we see are really important. But it also builds bone density because your bones are sensitive to vibration in an osteoblastic way. And then it also stimulates insulin-like growth factor, which is growth hormone for the bones and for the tendons. So you build bone density through osteoblastic stimulation and insulin-like growth factor, but you also build it through that vibrational tendency as well through insulin-like growth factor. So I try to look at exteroceptive through a whole body vibration platform, being on a surface that vibrates. So wood versus like a wrestling mat that won't vibrate. So I want my client to feel the vibration because they need vibration to stimulate external sensory feedback. And then using skin stretch. So I would use kinesiology tape, rock tape as a way to reduce falls and build exteroceptive awareness in the client. And then Naboso is the other product, the product that I developed to bring in exteroceptive awareness through the feet. 2-point discrimination texture through the bottom of the feet and the palm of the hands to help build that awareness. I want to, before we kind of get into a recap of everything, I want to take any questions that you might have to go all the way back from almost 4 hours from now to see that you are able to connect the story that I took you through to make sure that you're seeing this biopsychosocial influence connection and how you can apply it to clients with chronic pain, fall reduction, movement dysfunction, or disorders from a homeostasis perspective, from an autonomic nervous system perspective, from a exteroceptive, from a breathing. So let's start to see how we're connecting this so that we are walking away with some powerful applications we can take to our clients come Monday morning. Okay, and I'm just gonna go through here real quick to see. So Peter, your question on for type 1 or type 2, I'm guessing that is with diabetes, that you were asking with the central nervous system motivation. Is that what? It's actually with both. So whether your client is type 1 or type 2, the sequelae that diabetes type 1 or type 2 has on the nervous system, the retina, the kidneys, the peripheral nervous system, central nervous system, the result is the same because it is essentially oxidation and glycation that is doing it. The root cause of it is slightly different, right? Is it autoimmune to the pancreas, or is it from kind of lifestyle? So it would be both that you see that in, okay? So let's see. Excellent, okay. And I am going to see if the recording can be sent to you guys. If not, though, there's some great supplemental webinars that I can send you to delve in again. Okay, biopsychosocial. This is our perception and interpretation to how we relate to things, and then how that manifests itself in our body. Interoception and interoceptive awareness is the root of that, and it's expressed through the autonomic nervous system and how we breathe. I use as my anchor for patients and clients exteroception, or anything external sensory, because it allows them to anchor and ground in a way that they can connect to in an easier way. But mindfulness and mind-body connections is really what we're talking about here. It's just diving kind of into the details of the science of it. Now, if you're saying, well, how the heck do I apply this, Emily? is think about vagal tone in your clients. How can you just build in vagal tone practices with your clients? That's the mindfulness, that's the breathing, that's the chanting, that's the ventral vagus resets, that's the cold showers. So you're just thinking of vagus tone, vagal tone or heart rate variability in your clients. And then what drives that is their stress. So what's their relationship to stress, right? The more we can perceive our internal environment, the more we can regulate that stress. So we become in control of our body, both internally and externally. You're essentially giving your client power. That's really what you're doing, right? I'm giving you power to better navigate your chronic diagnosis, whether that's pain or a movement disorder or movement dysfunction. Is the more empowered you are by understanding these little tips and tricks, then the more you will be able to navigate. You're the one driving the car versus the pain or your diagnosis driving the car. Your quality of life and perception of that, your quality of life will go higher, and then all of your relationships will benefit, because people don't want to be around anxious or depressed or angry people that are not regulating. So it expands, very broad. If you are going to any of the other sessions that I am doing, tomorrow I'm speaking about the somatosensory system, but I'm giving research very specific to mood, memory, and movement as it relates to sensory stimulation. This will be external sensory stimulation. There's a lot of dementia research and depression research from a sensory stimulation perspective, Alzheimer's prevention based off of sensory stimulation. So I'll be going into that. And then of course, movement is the easy one to understand and grasp from that perspective. I am going to be sending you the videos on the ventral vagus nerve resets, the list of the books for our book club, and then the body questionnaire. I'm going to be doing that, and then a few key webinars that I did through EBFA Global, my education company. Both of the lectures that I'm giving through FAS, the Formal Functional Aging Summit, will be Friday at 11:30 a.m. I'm doing the science of the somatosensory system, mood, memory, movement. And then Saturday, I'm doing a peripheral neuropathy lecture at 11:30. And that lecture will go into both sensory and motor neuropathies. There's a lot of understanding of sensory neuropathies, but not a lot on motor. So if you happen to have you know, any like Charcot-Marie-Tooth is the most classic motor neuropathy, but I'm going to tie in what we see even with MS. 25% of MS patients will get neuropathy at some point. So I'll be going into that, as well as chemo-induced neuropathy and of course diabetic neuropathy, and then what you can do with that. Okay. Now, through FAS, any of the products are 25% off of Naboso, because Naboso is a Functional Aging Summit sponsor. So you just want to enter this code. It'll be emailed to you as well. And then we have a virtual trade show booth. So you can stop by, see some videos, stop by virtually and say hi. And we do affiliate programs. We do wholesale programs. We play a really important role in improving balance, posture, and gait in those with chronic neurological conditions. So if you haven't heard of the product, please do make sure that you stop by and see more, or you visit our website. So my education company is ebfaglobal.com. So if you want to see some of our free educational videos, you can do that off of our YouTube, and then Naboso is the website on there. Good. Woo. When you don't take breaks, you fly right through that. How about that? No lunch. Actually, no, you guys get lunch now for those that are taking 2 of them. Any questions? Did you guys enjoy? Did you find it new information? Did it kind of turn the light bulb on certain clients or patterns that you would see in your clients? Did it open a whole nother can of worms or Pandora's box for you to go down and start exploring? I hope so. You can just lie and say yes on here. So many light bulbs. That's great. Excellent. Good information for Peter. Thanks for staying. Well, it's actually not that late. What time is it in the UK, Peter? 7 p.m.? Gotta be about, okay. Almost 7 p.m. Perfect. All right, great. Thank you so much. Beautiful. Let's see if anyone had any questions. Good. We are also, just as a heads up, is that the Barefoot Training Specialist certification, our level 1, which is offered online, starting, I believe, on Monday, will be available through FAI. So make sure you stay tuned with their education, because it's going to be available via their platform. Okay, good. If you don't have any other questions, then I hope you guys have an amazing day, and I will hopefully see you all in my sessions tomorrow and on Saturday. Please look for my emails with the books and the videos and some of those webinars. And then when you see the email that comes in, if you have any questions related to this, do not hesitate to reach out to me. It's a topic that I really want to get more and more into the fitness and movement industry. So please do not hesitate to reach out. Okay, thank you guys so much. I believe there will be a recording. Please reach out to Dan, okay? It is recorded. I hope that they do make that available for you. Excellent. Thank you all. Thank you. See you in person in 2021, but online tomorrow.